Hear us, sir, properly? Can you see us?
Uh,
Can you hear us?
I can hear you.
Great, sir.
Yeah, when I have my slides up, I don't see you, but I saw you before I pulled my slides up.
Yes, now you can see us.
Here, let me.
Great, sir.
Yes, I can see you. Yes,
Great, sir.
I'm making it small so I can see my slides better. But
Surely, surely.
Camera feeding also will provide within 5 minutes. Until until
मैडम शुरू करना. Where are you, मैडम? Hello.
Internal microphone selection. Watching.
Check 1 2. Check mic test. Check 1 2. Check mic test. Check. Check mic test. Check.
Good morning, everyone. Welcome back to session day 2 of Deccan Hematolink 2.0. We are in Hall A and we have an insightful series of sessions lined up today. Without any further ado, let's begin session 5. I request the esteemed chairpersons to take their seats on the dais. Dr. Ganesh Pavde from Pavde Hospital, Nanded. Dr. Srinivas Reddy from Sai Srinivas Hospital, Hyderabad. Dr. Prashant, pediatrician. Dr. Vijay Misale from Sri Narayana Hospital, Nanded. Let's begin with our first session. Our session 1 is on a talk on adult ALL in 2025, a transformative global breakthrough by Professor Mark Lidzow, Mayo Clinic, Rochester. To begin the day on a high note, we have Professor Mark Lidzow from Mayo Clinic, Rochester, sharing his expert insights on adult ALL in 2025, a transformative global breakthrough. Let's welcome him. Over to you, sir.
Well, thank you very much. It's an honor to speak with you today, and I appreciate the invitation. I'm going to, in the short time I have, I'm going to talk about some studies that I've been involved in treating ALL with blinatumomab in the frontline setting. The study I'm going to talk about is has a backbone or a basis in a previous trial that we did in the ECOG, or Eastern Cooperative Oncology Group in the United States that I've been involved with for many years, when we collaborated with our British colleagues and did the UCAL12 ECOG E2993 trial. And the chemotherapy backbone the trial I'm going to discuss came from this trial, and I will go into the further details about that, but I just wanted to reference this previous study, which was published a number of years ago, along with a number of follow-up studies. So this is the E1910 trial that I'm going to primarily share today. And in this trial, we added blinatumomab to chemotherapy for adult ALL patients. So all patients with B lineage ALL received 2 cycles of induction chemotherapy, as you can see at the top. Those who achieved a conventional complete remission or a complete remission with incomplete count recovery, a CRI, stayed on the study. If they did not achieve a conventional morphologic complete remission, they went off treatment. They then received an intensification cycle with high-dose methotrexate and asparaginase for CNS prophylaxis. And at that point, they were randomized to either, on the right side, continue with 4 cycles of consolidation chemotherapy and then on to maintenance therapy, or they could go off to an allogeneic transplant during the course of the consolidation at the investigator's discretion with any conditioning regimen and any donor. We did not specify that. On the left side was the experimental arm, where we gave 2 cycles of blinatumomab by continuous infusion for 4 weeks within a 2-week break, and then a second cycle followed by the same 4 cycles of consolidation chemotherapy that the control arm got, along with 2 more cycles of blinatumomab, as you can see before and after the last cycle of chemotherapy. These patients could then go off to maintenance therapy or after the first 2 cycles of blinatumomab, they could go off to an allogeneic transplant. And you can see the stratification factors on the lower left. And this was a United States intergroup trial. We also enrolled patients from Canada and Israel, and it was a 1-to-1 randomization. So we did make some modifications to the chemotherapy backbone from the previous trial that I mentioned. We actually tried to make it more pediatric-like, and so we decreased the daunorubicin dose, as you can see. We changed E. coli asparaginase to pegaspargase, so the pegylated form of asparaginase. We added rituximab if the patient was CD20 positive. We changed prednisone to dexamethasone for greater CNS penetration, and we modified the dose of cyclophosphamide. Finally, we extended cycle 2 of induction from 28 to 42 days. Consolidation and maintenance were otherwise similar. And we did not give the pegaspargase in induction to patients at 55 years of age or older because we were concerned about excess toxicity. We also shortened the amount of dexamethasone they got. Instead of 2 weeks, they got only 1 week. So blinatumomab, as I think you're all familiar with now, is a bispecific T-cell engager molecule combining the variable region of a CD19 antibody and linking it to a CD3 antibody through a 5-amino acid linker that contains glycine and serine, and it brings a T-cell in proximity to the B lineage blast cell and lyses it. And this has been previously FDA approved for relapse and refractory B lineage ALL, and then was also approved based on the BLAST study that was done in Europe for MRD positive patients. So I presented the results of this trial at the ASH meeting, a late-breaking abstract session in 2022, and then we were finally able to get the study published in New England Journal last summer in late July, and I refer you to that publication for further details. So this again is the schema. So our objective, primary objective, was to compare the overall survival in the MRD negative patients who received blinatumomab plus chemotherapy to that of patients who received chemotherapy alone. Even though patients who become MRD negative with chemotherapy have in general a better prognosis, we know that many of them can still relapse and have residual leukemia, and so we were targeting that with the blinatumomab. And you can see some of our statistical assumptions here. We thought we needed at least 190 patients to be MRD negative and randomized. And our accrual goal was 488 patients. So we measured measurable residual disease centrally by 6-color flow cytometry in our Leukemia Translational Research Laboratory in New York with Dr. Elizabeth Paeta. And we used a cutoff of 10 to the minus 4 or 0.01% for positivity. Now we enrolled patients between the ages and 70. The Alliance Cooperative Group in the United States was planning an adolescent and young adult trial that would go up to age 40. So we had some overlap, but we didn't want to overlap extensively with that study. And so our lower age was 30. When blinatumomab was approved in the United States, the FDA said it had to be given by a 24 or 48-hour infusion, but they gave us permission to extend the bag length to 72 or 96 hours so that centers wouldn't have to change the bags on the weekends, which was difficult for some centers. So the median age of the patients was right in the middle of the range at 51 years, and our conventional or morphologic CR/CRI rate was 81%, with most of these being complete remissions. So this study went on for accrual of just under 6 years, between end of 2013 and the fall of 2019. Of the 488 patients, 286 reached step 3, which is where they were randomized, 224 MRD negative patients and 62 MRD positive patients. The group that got blinatumomab plus chemotherapy versus chemotherapy alone, the two groups had similar baseline characteristics. We had originally intended to randomize the MRD positive patients as well, but As you may recall, the FDA approved blinatumomab for MRD positive disease in March of 2018 during the course of the study, and we felt that we could no longer randomize them. And investigators actually were wanting to give the patients blinatumomab. So we no longer randomized them, and we assigned the MRD positive patients to get blinatumomab plus a chemotherapy. So this is the course of the patients through the study. So as you can see on the left, we enrolled 488 patients. 81% of these achieved a CR/CRI. We had a 4% induction mortality rate. And then of the 395 patients who achieved a remission, 109 did not reach the randomization step. And this was for a variety of reasons, which I list on the slide. Some died of either toxicity or recurrent disease. They had adverse events, and the investigator took them off the trial, and some patients withdrew from the study on their own. So the 286 reached the randomization assignment step at step 3. And this was the primary endpoint of the trial, overall survival in the MRD negative patients. And you can see the black curve is the blinatumomab plus chemotherapy group, and the red is chemotherapy alone. 3-year overall survival was 85% for the blinatumomab plus chemotherapy group versus 68% for the chemotherapy group. And we saw similar curves, which I won't show, for relapse-free survival. And you can see for both relapse-free and overall survival that the hazard ratio was low and the p-value was particularly significant for overall survival. And the improvement was primarily related to increased relapse in the chemotherapy arm, as you can see down at the bottom. Now, 20% of the patients went off to an allogeneic transplant, 22 in each arm, and that was just by chance that it was the same number in each arm. And 80% of the patients received 2 or more cycles of blinatumomab, and a little over half of the patients received all 4 cycles. Now, just for comparison, this is the overall survival in the MRD positive patients. We originally randomized 22 patients to each arm, and then an additional 18 were assigned. So that's why we have 40 in the blin plus chemotherapy and 22 in the chemotherapy arm. And although these curves separate because of the smaller numbers, a p-value is not quite significant. Now, we did a post hoc analysis to look at how patients did based on an age cutoff of 55 years, and recall that at 55 we'd omitted the asparaginase and induction and shortened the steroids. And you can see on the left, these are the patients less than age 55, and there's quite a significant difference in outcome with the blinatumomab versus chemotherapy with a highly significant p-value. In the older patients, we did not see a significant difference. The curves may be separating, but at the time of the analysis, the p-value was not significant. Now, exactly why this is, we don't know precisely, but Dr. Bajal Shah from Moffitt Cancer Center assisted with this analysis. And what we're showing here is the breakdown of high-risk molecular and genetic changes by decade of life. And so the first bar is, the purple bar is a pH-like and CRLF2. The green is MLL. The black is patients that are complex karyotype or hypodiploid or near haploid. And the gray are TP53 mutated. And you can see in the patients above 50 and especially above 60 that there's more patients with high risk, poor risk genetic changes. And so this may have played a role in not seeing a significant difference with the older patients. Now, this is a forest plot looking at different subsets of patients, and you can see the age difference, which we just highlighted. We looked at the BCR-ABL-like genotype. We sent samples from this study to St. Jude's Hospital in Memphis, Tennessee, to Dr. Charles Mulligan's lab, and he's a pioneer in assessing molecular genetics of ALL. And you can see there were trends toward improvement with the BCR-ABL-like or pH-like, and more so with the non-BCR-ABL-like. We did a combined molecular risk, which I'll talk about a little bit more in a moment. I'll talk a little bit more about transplant as well. And I'm just highlighting those areas. So this is the sophisticated molecular analysis that we did with Dr. Mulligan, and we looked at these many different subsets, and we categorized the patients as either favorable, intermediate, or unfavorable. Favorable are the high hyperdiploid. Some of the other genetic changes you can see there. The unfavorable are the ones we've talked about, including, in addition, KMT2A. We had quite a number of those. And then we had an intermediate group on the lower left. And if we look at a breakdown of how these patients did, if you look on the left side, the favorable risk patients did exceedingly well with blinatumomab plus chemotherapy, with no one relapsing and 100% survival. If you look over on the right, the unfavorable, I was encouraged to see that overall, and this is for all comers in the study, that adding blinatumomab did seem to improve outcomes with these patients, and the p-value was significant. The intermediate group, it may be a matter of numbers. I'm not sure why we didn't see a difference between blin plus chemo versus chemotherapy alone, but that's the results that we had with the intermediate risk patients. And we also looked at transplant outcomes by arm of the study, and we did not see a significant difference in outcome in the patients that went to transplant, either for overall or relapse-free survival, or they got blinatumomab plus chemotherapy or chemotherapy alone. Now, one of the questions that has come up is, do the patients with high-risk genetics, even if they achieve MRD negativity, still need to have a transplant? That has certainly been my practice up to the time of this study. I felt that even if a patient was MRD negative, their risk of relapse was going to be higher, and they would more likely benefit from a transplant. So we had small numbers here, and this is 50 patients with unfavorable risk. And we did a landmark analysis at 5 months post-randomization. You can see that we had 14 patients that got a transplant and 36 that did not get an allotransplant. And the outcomes actually look a bit better for the patients that did not have a transplant. So this has adjusted my thinking and certainly given me pause as to whether these high-risk patients, if they achieve MRD, they truly need to have a transplant. And I think this needs to be investigated further, but this is some of the data I want to share that we have for these patients. Now, the toxicity in the two arms was similar in most respects, but we did see more neuropsychiatric events in the blinatumomab plus chemotherapy patients at 23% compared to 5% with chemotherapy. And we defined this rather broadly. So if investigators reported the patient was having a headache, we considered that to be a neuropsychiatric event. So this varies somewhat from study to study, and you can't necessarily compare from one study to another. But certainly, if you're giving blinatumomab in this setting, you need to be cognizant that they could be at increased risk for neuropsychiatric events. And so, excuse me, I kind of jumped ahead. So on the basis largely of this study and some other studies, in June of last year, just before the full publication came, the FDA approved blinatumomab for a third indication now, and they defined it rather broadly as a consolidation for CD19 positive Philadelphia chromosome negative B-cell precursor ALL. And Amgen submitted this data to the FDA for approval. You can see on the lower left, with now a median of 4.5 years of follow-up, the benefit with blinatumomab is holding up compared to chemotherapy. Now, for those of you that follow this field, and particularly pediatric patients, at ASH this year, the Children's Oncology Group here in the United States presented a trial they did in NCI standard risk patients. These are patients generally between the age, I think, of 2 and 10 with standard risk disease, and gave them blinatumomab plus chemo and showed a disease-free survival advantage with of blinatumomab. And there was a publication, a phase 2 study that showed that blinatumomab plus chemotherapy was of benefit in KMT2A infants, as you can see on the left. And then on the right is the E1910 trial. And so the only group that hasn't formally, these are the pediatric, certainly that it's highly likely that blinatumomab will also be of benefit to these patients. So blinatumomab seems to be effective across the full age spectrum of patients, although again, as I mentioned earlier, in older adults, that's a little more questionable. So I can conclude by saying that this trial for the first time showed that consolidation of blinatumomab gives an overall survival advantage for adult patients with MRD negative, BCR-ABL, or pH negative B lineage ALL. Provided overall survival benefit to younger and somewhat to older patients, but certainly a greater extent to the younger patients. And we saw the benefit in the favorable and unfavorable molecular risk. And it's made one question whether BMT is essential in these patients if they achieve MRD negativity and get blinatumomab. And this certainly represents a new standard of care for this group of patients. So I think broadly, what this study and other studies have suggested is that number one, immunotherapy has a definite role to play in the treatment of B lineage ALL. I haven't talked about inotuzumab, but there's some interesting studies incorporating this into upfront treatment. There was a study done, a small group of patients by the Alliance group here in the United States in older patients where they gave inotuzumab as a single agent and then followed with blinatumomab. And the only chemotherapy these patients got was intrathecal chemotherapy, and showed encouraging results. So I think there's great potential for immunotherapy to improve the outcomes of these patients and in particular to potentially lessen the amount and the duration of chemotherapy that these patients need to receive. So with that, I'd like to acknowledge my colleagues in the ECOG Akron group on the upper left, the SWOG, Southwestern Oncology Group in the United States, and the Alliance Cooperative Group, along with our longtime collaborators in the former MRC, now National Cancer Research Institute in Great Britain. And I thank you for your attention. And if there's time, I'd be happy to answer any questions. Thank you.
Thank you, Professor Lizzo, for that enlightening session. Any questions from the audience? Yes, ma'am.
Thank you, Dr. Lizzo. That was excellent. So I had a question. Since MRD positive and negative patients are being treated the same, would it be something in the future that maybe we wouldn't do the MRD initially, but only after the blin and chemo induction, or maybe the consolidation, then kind of look at who's still MRD positive? Is that somewhere that we're going?
You broke up a little bit, so I didn't quite hear the
Okay, my question was
question fully. Could you repeat it?
Sorry. My query was that we're, in a sense, treating MRD positive and MRD negative patients similarly. Is that correct? And actually, rather than evaluating MRD earlier, wouldn't it be something that would be coming up that we would evaluate MRD much later to see if you're still positive later on?
Well, I think if a patient is, remaining MRD positive after induction therapy or earlier in their course, then I would be concerned that that patient isn't going to do as well. And I would be inclined to take them to transplant if they're MRD positive, even if you say give them blinatumomab and they become MRD negative. So I don't think you should delay measuring the MRD. The ideal time point for measurement of MRD is not precisely defined. A common time point is at about 4 months after treatment, but it's something that needs to be monitored at periodic intervals. So for an MRD positive patient, I would consider taking them to transplant sooner rather than later. If a patient's MRD negative, you give blinatumomab, then I think you can monitor them closely and not necessarily need to intervene with transplant.
Yeah, thank you.
Hi, this is Satya Yadav. So wonderful talk. We learned a lot. I'm a pediatric hemato-oncologist, so it's wonderful to see the outcomes improved so much for adults with blina introduction upfront. So do you think that in future, like CAR T upfront would also be an option for elderly patients, or at least those who are MRD positive after blina and this thing? So what are your thoughts about CAR T being used upfront in elderly ALL patients? Thank you.
Well, I think that's definitely an interesting thought and something that needs to be considered. And I think particularly for MRD positive patients. And I think particularly, if a patient has gotten blinatumomab and now, is either staying MRD positive or becomes MRD positive after the blinatumomab, then I think there's definitely a role for CAR T cell therapy in that setting. And we've started to talk about the possibility of doing consolidation with CAR T cell therapy, but even in, say, maybe a patient that's MRD negative, it certainly one would think that they could also benefit. But we haven't got quite to that point, I think, where we want to necessarily introduce that at that time point. And it's a matter also of the accessibility of CAR T cell therapy and the expense, and so I think that also has to be taken into account. But I think there's definitely data showing that CAR T cell therapy is effective in MRD positive patients, and I think it would have a role there. And I think the elderly population would certainly be a group to consider, given their lower tolerance for chemotherapy and their higher risk features.
Thank you, Dr. Thank you, Dr. Lizzo. Thank you so much.
You're welcome. Thank you again for the opportunity. Take care.
Now we proceed with our next session. I would like to invite Dr. Tulika Seth, Professor Hematology, AIMS, New Delhi, to talk on simplifying the complexities of hemolytic anemia. Over to you, ma'am. I request all the speakers, chairpersons, and panelists to collect the mementos in podium near photo booth. Thank you.
Okay, so thank you so much. I've kind of made a mixed bag. There's some simple basic cases and the basic approach to hemolytic anemias, and I've also thrown in a few interesting cases for my more senior colleagues. So hemolytic anemias, as you all know, are defined by the premature destruction of red blood cells. So they have a shortened red blood cell survival from the usual 120 days to less than 100 days. This is a very broad basket of disorders. Some are chronic, some are sudden and life-threatening, some are immune-based and some are non-immune, others are inherited or acquired. There's intravascular or extravascular, and in some conditions you can actually have both intravascular and extravascular pathology. intracorpuscular and extracorpuscular. So it's important to keep them as a differential for any normochromic normocytic anemia or any macrocytic anemias. So we need to basically demonstrate two things when we're trying to solve the puzzle of whether it's a hemolytic anemia or not. One is to show increased red cell destruction, and that can be shown by an increased unconjugated bili, increased LDH, decreased serum haptoglobulin, which is now available in many labs, and by showing an increased red blood cell production. So there's reticulocytosis, polychromasia, macrocytosis, and other clues to the etiology can be abnormalities in the red blood cells seen in the peripheral smear. So the hallmark of hemolysis is considered to be anemia and jaundice, and sometimes hemoglobinuria. However, there's a caveat to that. Jaundice can vary depending on the rate, and many times the indirect bilirubin may actually not really be elevated if the liver is able to handle this. And the symptoms of anemia will vary a lot, because if it's a very gradual anemia, there may not be severe anemia, or even if there is severe anemia, if it was very gradual in onset, the patient may not be very symptomatic. And things like gallstones, hepatomegaly, cholestasis may not be there in all patients. So when we're looking at the approach, again, first of all is you have to have a high index of suspicion. So there may be some clues that may trigger this. Then you have to document whether there's red blood cell destruction and increased production. And then you need to, once you've established that it's a hemolytic anemia, you need to identify the etiology and the site. So there's different classifications. Some people like the hereditary and the acquired. There are different lists that you've probably memorized when you were students, but often that's not very useful. What's more useful is to kind of look at the mechanism. So the basic tests are done to look for evidence of hemolysis, and then the secondary tests are to look for the etiology, and a peripheral smear and a direct Coombs test are two of the initial basic tests that we do, followed by clues from this will then guide us into the other tests that we are going to be doing. So many of the other clues will be from the peripheral smear, so whether there are spherocytes, schistocytes, blister cells, ghost cells, sickle cells, target cells, if there's a red blood cell agglutination, microcytic hypochromic cells. So all of these are very important and can guide you in ordering the specialized tests. So if you see a lot of spherocytes and you have a direct Coombs that's negative, then you may be looking at spherocytosis. So you can go ahead and order the incubated osmotic fragility test. But spherocytes are not pathognomonic for hereditary spherocytosis and can be found in autoimmune hemolytic anemia, post-transfusions, and many other things. Similarly, it's important to look at the smear for other enzymopathies and hemoglobinopathies. The reticulocyte count is extremely important, and it's important to make sure that you have a proper prep in order to not miss the reticulocytes. And once you've counted the reticulocytes, you need to then evaluate them and do a correction of the reticulocyte for the degree of anemia, because an uncorrected reticulocyte count can be fallacious. So the site of hemolysis is important because that really helps us in the investigation, and usually the hemolysis is either intravascular or extravascular, and occasionally maybe both. The mechanisms include poor deformability leading to trapping and phagocytosis. It could be antibody mediated, or there could be fragmentation due to microthrombi, direct mechanical trauma, oxidation, and even direct cellular destruction. So first of all, extravascular. This is the more common group that we encounter, and often it is antibody mediated, or there can be other mechanisms like sequestration, phagocytosis, poor red blood cell deformability, etc. And the common causes that we can see are warm autoimmune hemolytic anemias and many of the inherited hemoglobinopathies, and again, infections and drugs can be in this group. In the intravascular, this is a little bit less common, but it's a very important group. And the free hemoglobin that is released by this leads to the hemosiderin and hemoglobinuria. And many of these disorders can be actually quite serious, like PNH, cold autoimmune hemolytic anemia, mixed autoimmune hemolytic anemia, and the MAHAs, etc. So there's a long list of disorders. So, but you don't need to worry. If you approach it methodologically, you'll be able to figure it out. So this is a simple matrix that we often use. So there'll be certain things that will be increased in all hemolytic anemias, like your retic count, your LDH, your unconjugated bili, and certain things will be reduced in most, like the haptoglobulin. And there'll be certain factors which will be present in either intra or extravascular hemolysis, like plasma hemoglobin will be more in your intravascular, and as well as your hemosiderin and hemoglobinuria. So this will be able to help you in distinguishing which type of hemolysis you are dealing with. So following this algorithmic approach is important, and we usually start with a direct Coombs because that's a very simple test that can be done, and you can separate your conditions from immune and non-immune. The history is also very important, so finding out the family history, assessing whether your patient is sick or not. If there are different etiologies that you'll find in a sick patient, others that you'll find in a well patient. Also in adults, make sure that you're ruling out chronic lymphoproliferative disorders as well as many malignancies, because autoimmune hemolytic anemia can present as a paraneoplastic syndrome in many disorders. And of course, then there's the community mycoplasma, and medications are an important and often ignored group that can lead to this. So just a few cases to kind of go over this. So this was a 6-month-old child who was admitted in the pediatric ICU with a hemoglobin of 2. The patient had hypoxic encephalopathy, was actually put on a ventilator, and did not have any fever or any other etiology, and we were consulted. The child had been having severe anemia and had actually received several blood transfusions at an outside hospital, and we evaluated the patient. So you can see there was definitely increase in direct bilirubinemia, LDH was high, and the Coombs was positive. So in this case, we are looking at a immune mediated hemolytic anemia. The DCT is usually positive in a warm type AIHA, and it can be either polyspecific or monospecific, so we can kind of get a lot of information from that. And in an older patient, we would always look for other things like chronic lymphoproliferative disorders. In a younger patient or even an older patient, common variable immune deficiency is something to look at. And this is a simple algorithm to work up patients who may be having AIHA. So once you figured it out, you then can see if it's IgG related or C3 positive. So when we look at all the autoimmune hemolytic anemias, the commonest group are the warm autoimmune hemolytic anemias, and most of them are iatrogenic. We often don't know the cause, but there may be viral triggers. Other infections can also be there, as well as malignancies, transplant, the primary immunodeficiencies, for which we have a talk later on. And then we have the other group, which are usually cold or mixed. And this group is less common, but often more difficult to treat. And you can easily figure out what you're dealing with, a warm type, a cold agglutinin disease, or a paroxysmal cold hemoglobinuria, again by a simple algorithmic approach. So once you know that you have an AIHA, it is very important to treat. This can be a life-threatening disorder, and the most important drugs in this treatment are steroids. So in this case, we gave us a pulse of steroids because the patient was severely sick. Many times you'll find patients in the OPD who may not be as sick, and they can be given oral steroids. We also gave IVIG in this patient after checking, because this was a small child, but usually if you're giving IVIG, it's a good idea to check for a CVID. This patient stabilized within a few weeks, and the steroid dose was kept the same. It's important to keep the steroids at a high level for at least 1 or 2 months, or until the hemoglobin stabilizes. But after a few weeks, the patient was readmitted. He had another accelerated hemolysis, and up till this time, the patient had received 1 month of high-dose steroids, both in and outside the hospital. And there was no other infection or anything that could have precipitated this. So we gave this patient rituximab, and this was something that we published almost 15 years ago. So rituximab is a very important thing that can be used for relapsed patients or refractory patients. Now we have many other newer products that can be done, especially for chronic autoimmune hemolytic anemia patients where we are finding that they are steroid dependent. We can give rituximab alone. Now rituximab plus bendamustine can also be given in adults. In the chronic autoimmune hemolytic anemias who are refractory or are steroid dependent, you can also have newer agents like ibrutinib, sutimlimab, and even dara and ofatumumab have been used. Next case is a 19-year-old who came with severe headache and pain, and she had slurring of speech. She came to us with a history of progressive fatigue over a few months, and the MRI showed that she had an ischemic stroke. The blood counts showed that she had anemia. She also had a high LDH, and the retic count was slightly elevated. The DCT, however, was negative, though there was polychromosia. There was no spherocytes, so no other abnormalities, and the MCV was slightly on the higher side. The urine was positive for hemosiderin, and she had a high plasma hemoglobin and undetectable haptoglobulin. So we were suspecting PNH, and PNH, as we know, has intravascular hemolysis. There can also be thrombosis that can occur, and some patients may even have evidence of bone marrow failure. So this is a progressive disorder in which the red blood cells are not protected by the shield of terminal complement inhibitors, and they are prone to hemolysis, and this leads to the multiple symptoms that we see in patients with PNH. And the hallmarks, of course, being hemoglobinuria. These are very severe and can lead to many complications in these patients. And often we get PNH patients referred from nephrology and other departments because of the complications that they have. So there's a lot of problems that these patients have, primarily the intravascular hemolysis, which can lead to jaundice, abdominal pain, and other problems. The thrombosis, which can be quite severe. And some patients may go on to develop bone marrow failure. So it's important to identify these patients. Just having the PIG-A mutation doesn't predict the PNH. We need to look at the clone size. So patients who have type 3, where it's almost a total deficiency, are the most severe patients, and they need the most attention and treatment. Otherwise, they may succumb to the disease. And as I said, there are many symptoms to this disease. So sometimes patients may present insidiously, and it's important to keep this into the back of your mind. The catch criteria can often help you in suspecting, because PNH can be there in bone marrow failure syndromes. It can also be there in myelodysplastic and aplastic patients. So by diagnosis, we can do a gel card, which is usually easily available in even smaller centers, but in the larger centers, we will go for a flow cytometry, because that will help us in identifying the subtype of PNH. And here you can see that the white blood cells are showing the double negative cells. So therapeutically, there used to be not much that we could do. We would only really do supportive care, but now we have several complement inhibitors. The other supportive care also includes anticoagulation, iron, and etc. The targeted therapies are now available in India. We have eclusizumab, which I've been actually using in several of my patients for several years now. And we now have a trial that's going on with a novel C5 inhibitor. The newer complement inhibitors are better because they have less risk of infections. The original terminal complement inhibitors had a high risk of meningococcal and other infections, which are not there with the newer ones. Transplant is an option, but there's often a lot of morbidity and mortality, and so even if we're going for transplant, it's a good idea to use a complement inhibitor as a bridge to transplant. Transplant itself can cause a lot of problems, and we can see transplant-associated TMAs, and these are also important, and often they are managed with complement inhibitors. And the drug-induced hemolytic anemias are often attributed but not always identified. And this was a very large study that was done in France, where they actually did a pharmacovigilance record. They evaluated each and every case of suspected hemolytic anemia. Just 1 minute. And what they actually found was they found 112 drugs that can actually lead to autoimmune hemolytic anemia. And if you see this, many of these drugs are common drugs that we use. So it's important, especially in ICU patients, to kind of think of this. The last case is a patient who we actually learned something. This was a patient who'd always been pale. He occasionally had some skin bleeds. Nothing really was jumping out to us except for the anemia and the fact that it was DCT negative. The anemia looked fairly unremarkable, did not respond to hematinics. The thing that was alarming was that his cholesterol was extremely high, and he had these unusual stomatocytes and macrothrombocytes in the smear. Now we are using NGS for diagnosing hemolytic anemias, and since all of his usual workup for hemolytic anemia, including HPLC and other things, were normal, we decided to do an NGS on him, and he turned out to have a cytosterolemia, which is a very unusual type of hemolytic anemia, but has been reported in India. It's a Coombs negative hemolytic anemia. And these patients actually, because of the high cholesterol, they can have bleeding disorders and they have a high risk of cardiovascular disease. And all you need to do is change the diet and give them some anti-cholesterol medicines, and they do really well. So this is, don't get alarmed when you see this long list of diseases that lead to hemolytic anemia. If you follow an algorithmic approach, you will easily come to the diagnosis. Thank you. Okay, any questions? No? Okay.
Thank you, doctor, for the wonderful session. For our next session, we have a panel discussion on child with recurrent sepsis. Is it time to think PID? I would like to invite chairperson for this session, Dr. Ramana Dandapudi, sir, pediatric hemato-oncologist, Little Star Hospital, and the moderator, Dr. Satya P. Yadav, hemato-oncologist and bone marrow transplant specialist, Medanta Hospital, Delhi. And our panelists for the session are Dr. Anand, pediatric oncologist, hematologist, Sri Shankara Cancer Foundation, Bangalore, Dr. Navya Sri, hemato-oncologist, Omega Hospital, Dr. Rasmi Palasari, pediatric oncologist, Ramaya Memorial Hospital, Dr. Ravindra Gaud, senior consultant pediatrician, Yashoda Hospital, Hitec City, Dr. Shirisha Rani, hematology and BMT physician, Rainbow Hospital, Dr. Anurag Reddy, medical oncologist, Dr. Nishad Dakate, senior hematologist, Nagpur, Dr. Barshini, pediatric hematologist, Rainbow Hospital, Dr. Chandana Marreddy, pediatrician, Hyderabad, Dr. Reshma Roshan, hematologist, Sahyadri Hospital. I request all the speakers, chairpersons and panelists to collect the mementos in the podium near photo booth. Over to you.
Thank you Ganesh and Yashoda Hospital for this wonderful meeting and an opportunity to be here and discussing an important topic. So we are going to discuss a child with recurrent infection. Is it time to suspect primary immunodeficiency? And we have a lot of panelists, so hopefully we'll have good discussion. And so whenever we have like a child with repeated infections, or in general for pediatricians here, anyone among the panelists would like to tell them that when to suspect that this child may be having an underlying immune problem instead of just a normal infection, which we all treat with antibiotics and children recover. So any one of the panelists, maybe on this side, all women team, anyone wants to add that when a pediatrician should think that this child is having too many infections and not one too many. So, yeah. It's mute. Yeah, now it's okay.
So good morning. So any child with unusual infection at an unusual site, severe failure to thrive, and prolonged usage of IV antibiotics and recurrent hospital admissions, even on requiring prolonged oral antibiotics and repeated hospitalizations, is someone who we suspect immunodeficiency.
Absolutely. So perfect. Unusual site, unusual infection, need for prolonged antibiotics, like more than a month of oral antibiotics, or need for hospitalization with need for prolonged IV antibiotics, like more than 2 weeks, like meningitis or deep-seated infections, recurrent abscesses, those sort of things. So this is when you suspect. And a thrush which is not going, oral thrush or the perinappy rash which is not going away despite proper treatment. So what we will discuss is we'll introduce the PIDs and few cases we'll discuss. So whenever a child has a recurrent infection, you should think of acquired immune problems first and then think of primary. So in the acquired, it can be like the child might be having HIV. So HIV should always be ruled out. Leukemia, blood cancer, so that may be a cause of repeated fevers. Diabetes, blood sugars being high. Nephrotic syndrome, they are edematous, they can get repeated infections there. Post-splenectomy children, thalassemia or other where spleen has been removed, they'll get infections and fever. Post-chickenpox, your immunity goes down, or post-COVID, we had seen a lot of infections and we thought maybe they are having PID, but it was just post-viral thing. But once you have ruled out acquired and you suspect that this is something unusual, then you look at the systematic way of B cell, T cell defects, combined immunodeficiency, neutrophil defects, complement defects. So this is the immune system. If you look at there, at the top is a stem cell. And if at the stem cell level something goes wrong, then it is reticular dysgenesis. Here you have bone marrow failure, your bone marrow is not working, and you don't have T cells, you don't have B cells, you don't have anything, any immune system. So it's not a very good thing to have. Then if you go towards lymphoid progenitors, so if your T cells and B cells are not properly made, it can be severe combined immunodeficiency. And as you evolve further, there can be DJOS syndrome where in the X-ray the thymus is missing, or there can be bare lymphocyte syndrome where CD45 expression is not there in the T cells. Wiskott-Aldrich, we will show you few cases. And then on the other side, in the myeloid, if there is neutrophils are not there, severe congenital neutropenia can be there, chronic granulomatous disease can be there, leukocyte adhesion defects, etc. So we'll go through few cases. So before we go to cases, this is the bubble boy, and anyone in the panelists would like to comment on the other side about the story of this child, bubble boy, to the audience. Anyone on the other side? Yeah. So Robert Good performed the first bone marrow transplant for a non-malignant disorder, and that was for severe combined immunodeficiency, and that was in a 4-month-old baby who was 11th male child of the family. Like 10 male children had died of immunodeficiency in that family, and this was the 11th child. So because it was an X-linked disorder, only boys were suffering and the girls were healthy. So his sister was a full match donor, and they did a first bone marrow transplant for this child, and they survived. But the bubble boy story is different. This boy had no immune system, severe combined immunodeficiency, lived in a bubble for many, many years, till he was 11 or 12 years old, and was absolutely fine. But there was no donor available. Finally, a mud transplant was done for him a bit later, and at that time he died of complications of transplant with a lymphoma, a post-transplant lymphoproliferative disorder, EBV driven. So this severe combined immunodeficiency, the children cannot live beyond 1 year if proper care is not given. This bubble boy lived in a bubble in a sterile environment, could live for 11, 12 years. Okay, so whenever you have a child with suspected immunodeficiency, you want to look at the lymphocyte count. So I would like maybe Dr. Rasmi or Reshma, that in a newborn, if you have a newborn and CBC is done, when should you suspect that this lymphopenia is like a bit too much, like it's very low, and we should screen the child for like late, or keep an eye on that child?
Am I audible? Yeah.
Yeah.
So the total count
itself is difficult, especially in the newborn period, to say what is normal or not normal, because typically you expect a high white cell count. Then is it too high, as in like an LAD? And in the differential, is the lymphopenia too low, as in a SCID? It's a little tricky to
So
call.
3,000 is the cutoff. Like once your T cells are your lymphocyte count
Or
less than 3,000 at birth. So these children should be monitored. Maybe at 1 month you repeat the count.
Yeah, because normally like that lymphocyte count, the cutoff is much higher in that newborn period. That's what I was trying to say, because you do expect a higher count, and so the cutoff is 3,000. And a lot of the time, because this is not ingrained into us.
So what should the pediatrician order? Like if at 1 month the lymphocytes are still low, then flow cytometry, what should they look for?
So the lymphopenia should trigger a basic workup to look at the lymphocyte subset as well as the NK cell enumeration, because the deadly ones, the ones we need to identify upfront and think about transplant or some kind of supportive care to prevent infections, are basically the SCID variants. So here, a basic flow cytometry to enumerate how many T cells are there, B cells are there, and how many NK cells are there will give you a almost clear picture in terms of whether you're dealing with a SCID or not. Followed by an immunoglobulin profile. Immunoglobulin profile, again, at the age of 1 month, just before vaccination, when the maternal immunoglobulins are there, you have to, like, again, the criteria or the limits are very different at that age compared to your adult limits. So 2 things to remember here is the CBC, the lymphocyte counts, the cutoffs are different in newborns and younger age group than older age group, and same with immunoglobulins. So any lymphopenia, like Sir said, of less than 3,000 should be followed up, because once you miss that SCID before the age of 1 month, 2 months, by 3 months, 4 months, they become extremely sick, they start losing weight, and it's too late to intervene.
So wonderful, thank you. So early diagnosis is key in severe combined immunodeficiency. If they are referred early to the transplant center, results are excellent. In US, there is a newborn screening program where they look at the TREC levels, the T receptor excision circles in the blood, and those who have low TREC levels, they are suspected to have SCID, and they have done further tests, and then transplant is done as early as 1 month of age, and there's more than 99% success in such children in US. So early diagnosis is very, very important. So I will show you a case, a 7-month-old boy who came from Iraq with recurrent chest infections and severe peeling of skin since 1 month of age. And in the past history, he was hospitalized multiple times in the home country and needing IV antibiotics, investigated for immunodeficiency, as Dr. Rashmi had shown that B cell, T cell subsets were done, and they showed T cells were absent, B cells were also very less or negative, NK cells were present. So this was B minus, T minus, B minus, NK plus sort of severe combined immunodeficiency. A genetic test was done which showed RAG1 mutation. And this was the skin of the child. So you can see that how badly the skin is affected. This is Oman syndrome, which you sometimes see the skin peeling, and erythroderma in severe combined immunodeficiency. So skin is a window to our immune system. So always have a good examination of skin in any baby coming to your clinic. So this is known as leaky SCID also. These are autoreactive T cells. And here the T cells will not be low, the T cells may be high. That's possible. So as we previously had shown, we can look at various combinations. So if we look at this child, T minus, B minus, and NK plus, that's the last one. And in that RAG1, RAG2 mutations are the common ones which are there. So coming to HLH, this is very common, so I'll go to that side of the table. So when do you suspect HLH, or when you think of doing tests for HLH?
Any child admitted in the hospital with high fever prolonging beyond 3 days, I think we should be skipping HLH in the mind, with of course associated cytopenias, if there is more or 1 or 2 lineage of cytopenias present in the child. And any family history of similar sibling death or persistent fever in such children, so we should be thinking about it. Of course, we have to investigate after that.
Absolutely. So in our hospital, we had done a study that we looked at all the serum ferritins which were ordered in our hospital, entire hospital. We went to the biochemistry and pulled out all the records of serum ferritin. And we found that any serum ferritin value more than 5,000, the mortality risk is higher. And values more than 10,000, mortality goes up further. So there is a straight away correlation between ferritin and mortality. It's a simple low cost test. So anyone coming to emergency who's looking sick, has fever, a ferritin can be ordered, as simple as that. It's very low cost test, and if it is high, then you should be alert that HLH and other things, and look at the CBC also, which is available. So if there are cytopenias, high ferritin, high fever, these three things are present, look at liver function test also, because when you have HLH, your LFTs are usually deranged, and their SGOT-peters are quite high. So even you don't have full 5 criteria which are to be fulfilled, but if the patient is looking sick, you may suspect HLH and start treatment. So Reshma, if you'd like to comment on the inherited or the familial HLH, like when should we suspect that this could be familial, and what are the various types of familial HL?
I think age should not be a criteria for suspecting familial. It is present across the ages, but obviously it's a child. We should first think of familial rather than secondary. Although secondary is also quite common. Any infection can lead to an inflammation and can precipitate HLH. Our practice has been, at least till in 40, we definitely do a HLH genetic panel. And it is not like only known these genes. Recently, we diagnosed a TET2 mutation in a child presenting as HLH. I checked the parents, both are heterozygous, and the child is homozygous. It's, I think, the first known case. It has been an adult, it has been associated with some lymphoma and immunodeficiency. So it is very important, even if you don't get these few genes, please go for whole exome if you are very strongly suspecting that, because they had a family history of death with HLH, and it was the second child. So,
thank you. So if we look at this chart, that when our normal immune system and the one where the HLH is present, on the left hand side uncontrolled infection and HLH, genetic HLH, on the right hand side everything normal. So if you see that perforin and granzyme, red and the green dots, they are needed to kill the target cell, to cause holes in that and kill it. So the T cells, T lymphocytes, they have to be triggered and activated, and then these cytotoxic T and NK cells, they have to have a maturation of this perforin and granzymes, polarization, docking, priming, fusion, and degranulation. These are the steps. So if there is a mutation in any of these steps, that thing will not happen. So that means your T cells and NK cells are activated, they get a signal that there is infection, but they are unable to kill the infection. And that's why they proliferate more and more, and they send signals to macrophages, and macrophages and T cells cross-talk to each other, and both increase in big numbers and get activated. Serum ferritin goes up, the macrophages in the liver get activated, and you get deranged LFT, and patient becomes very sick. So this is the pathophysiology why you get HLH, and familial HLH needs a bone marrow transplant as a curative option. Okay, so now we come to Wiskott-Aldrich syndrome. So I'll go to that side of the table. And it's an X-linked disorder. So when should we suspect that it could be Wiskott-Aldrich in a child?
Thank you, sir. So it takes back to me during my MD, the first case of Wiskott-Aldrich I saw was a child who was roaming around the hospitals being treated as chronic ITP. He was probably 2 years old child being treated, was on steroids for a very long time, and by the time he came to us, he had severe eczema, and the smear and the peripheral smear showed small platelets. So any child with persistently low platelets not responding to your treatment and has eczema and features of recurrent infections, we need to suspect Wiskott-Aldrich.
So as a hematologist, or on a peripheral smear, what should they look at, or in the CBC, the size of the platelets? Would you like to tell the pediatricians that a simple test which can be there?
The mean platelet volume will be low.
So smaller platelets. So MPV would be low. Mean platelet volume would be low in a child with Wiskott-Aldrich syndrome. They will have thrombocytopenia but have smaller platelets. And that's very, very characteristic, and that would give you a hint. Plus, if they have skin manifestations, eczema, and black stools can be there sometimes, and drop in hemoglobin and recurrent infections. So it happens in boys only. It's an X-linked disorder, and there is a spectrum. Sometimes you may just have thrombocytopenia only, and rest of things are not there. But in others, it may be more severe, causing everything. So as pediatricians, whenever you are suspecting primary immunodeficiency, there can be 3 presentations. One, repeated infections, what we are discussing. Second, autoimmunity. They may have autoimmune problems. So you have autoimmune destruction of platelets here. So that's, and there can be other, in HLH also there can be autoimmunity associated. Third is cancer. There can be leukemia, lymphoma in a child with primary immunodeficiency or EBV-driven lymphoproliferative disorder. Okay, so now we come to B cell defects. So on this side of the table, if we can just tell when should we suspect that there can be immunoglobulin problem in a child, what sort of infections they get when we suspect it can be X-linked A gamma globulinemia, or how we go about it. Yeah.
Good morning, everyone. Usually with B cell defect, it's the bacterial infections are more common. So whoever getting recurrent abscesses and requiring prolonged admissions in hospitals and IV antibiotics, we should suspect B cell defects.
Yeah, so there is something known as job syndrome where recurrent staph infections are there, and there is hyper IgE. So you should do immunoglobulin levels, and if IgE levels are high, it could be job syndrome. Or your IgG levels are low, or everything is low, it can be X-linked A gamma globulinemia, where there's a BTK gene mutation is there. Now we have BTK inhibitors. Our adult oncology colleagues are using ibrutinib frequently. There's a congenital condition where there's a BTK mutation and they can't make immunoglobulins. So I'll show you a case. An 11-year-old girl presented where there's a history of consanguinity in the family, and the child came with itching for 3 years and skin and mouth lesions for 6 months. She was initially diagnosed as tuberculosis and given ATT with steroids, but no response. Past history of recurrent cough, cold, and diarrhea. Family history, 2 children had similar problems and they had died. One got leukemia also. This was the skin. If you look at the skin, is a big window to our immune system. Here you see that there is multiple weeping eczema all over the body. Atopy is there. Dystrophic nails were there, and viral herpetic eruptions were there. Molluscum contagiosum was there in this child, and this child had high IgE levels, hyper IgE, but this was autosomal recessive. So Job syndrome is autosomal dominant and has usual staph infections and pneumonias. And when you have autosomal recessive presentation and hyper IgE, this is a combined immunodeficiency where there's skin infections and recurrent chest infections. And this is because of DOC8 protein mutation. You have less deficiency of DOC8, and that leads to all these problems and needs a bone marrow transplant. CGD. So if Rashmi or Reshma, anyone would like to comment, how common is CGD in your practice and how they present?
So,
just switch it on.
CGD is, it's not all immunodeficiencies are rare. CGD is one of the rare immunodeficiencies, but the classic presentation, so we had one of the first immunodeficiencies that I diagnosed in my current practice was actually CGD. So this was a child who started having these small abscesses in the neck since the age of about 3 to 4 months. It was never severe, but would not heal for a long time. And then the pediatric surgeon was involved in IND clearing. Then after months, it would heal. And she was the one who actually flagged it and sent the patient to me. But probably by that time, he was already a year and a half. So, but the only major infection that he had then, till then, was actually these recurrent lymph node, like lymphadenitis. Then that would suppurate and form these sinuses and would take a long time to heal. He didn't have any other infections. But CGD spectrum is very big. They can have large lung infections, but classically these cold abscesses, these abscesses, pus collections that take a long time to clear up is a hallmark of CGD.
Thank you. Yeah. So wonderful. So the key thing is staph infections and aspergillus infections. They are common in people who have this CGD, where the cells don't have the oxidative burst to kill the bacteria. And here, if you see this, transplants is a great option. More than 700 transplants done with 85% success rate. So early diagnosis CGD and a bone marrow transplant is a curative option here. Then congenital neutropenia. So this child presented to a surgeon with a hemangioendothelioma. The surgeon was operated this child. PAC clearance was given. The TLC was 21,000. No one looked at the neutrophils, which were just 1%. The differential was not looked at. The child was operated. Then he had high fevers and sepsis, and post-surgery, there were a lot of problems. Then we looked at the repeated CBCs. They were all like neutropenia, severe neutropenia. So we did a genetic test. Elaine mutation was detected, and it was severe congenital neutropenia. GCSF was given, and the child was doing well. So most of the congenital neutropenia can initially be managed with high dose GCSF, not normal dose. You have to go like 10 to 20 times higher than the normal GCSF dose. And eventually they may need a bone marrow transplant. But always look at the differentials. That's the message.
Can I make
this
comments?
child, if you look at, please.
So one more thing commonly we see is cyclical neutropenias.
Yeah.
We have had some patients who come once in 1 month, one and a half months with mucositis and sometimes skin infections and
Cyclical neutropenia is another common entity. So you should have serial CBCs and see when is the dip coming and then cells coming up. So this is another Amberger syndrome where if there is a triad of lymphedema. You see the child's leg and there is deafness and they have neutropenia. And they have GATA2 gene mutation, which has a huge spectrum. GATA2 insufficiency can cause AML, can cause MDS, can cause aplastic anemia, can cause monomax syndrome. So it's a new entity described in last 15 years or so, but we are seeing it quite often. I have transplanted 3 children with GATA2 insufficiency. So that's another cause of neutropenia. So Shediac Hagashi is something again rare. A 3-year-old child presented with recurrent respiratory infections, and this is the look, hypopigmented, and they get gram-positive, gram-negative infections. They are prone to EBV infections. So this is again can lead to HLH because list protein is required for the maturation of perforin and granzyme in the T cells. So because this list protein is missing, so they are unable to kill the infections, and they can get EBV-driven lymphoproliferation and HLH. Okay, so last, Carmil-2 deficiency. This is an example of how rare disorders present these days. This is something very, very unusual. This child came to my OPD with diagnosis of primary immunodeficiency number 56. He brought a report. I have got this disorder. I said, what is this? I have never seen primary immunodeficiency number 56. I Googled it. It showed that there is a Carmil-1 protein which is missing in these children, and they tend to get leiomyoma tumors, and they get CMV infections, recurrent infections, diarrhea can be there, and this is sort of a combined immunodeficiency. So we looked at this child. He had persistent CMV infection, which was not going away, needed Ganciclovir, other things, and had diarrhea and bit of eczema, skin rash. So usually most combined immuno have skin problems also, and then had a transplant and is doing okay. But our whole exome sequencing and genetic testing is available. So nowadays we are picking up rare disorders, and we don't know what to do with that report. And that may be the first in the world, second in the world, and no data in the internet. So it becomes very, very complicated. But it's a boon that we have these tests available. But we should go by the symptoms. Is the child really suffering? Is this mutation something known as a cold mutation and a hot mutation? So hot mutation means likely to be pathogenic, and cold is unlikely to cause any problem. So discuss with the genetics people what a mutation means, and does the child needs a treatment or not. Sometimes don't just act on the mutation, but see the clinical correlation. WHIM syndrome is something, again, very, very rare. So you have warts, hypogammaglobulinemia, low IgG levels, infections, and your neutrophils are unable to move out of your bone marrow. They are just sitting there. They are unable to move, and then that's why there's relative neutropenia. So this we saw with dasatinib in one of the children being treated for ALL, and we reported it that maybe it was an acquired WHIM syndrome. So again, something rare. So in conclusion, recurrent infection, always rule out immunodeficiency. That's the key message. Primary immunodeficiency, good history is important, like family history. If a child has died of some infection, you have to rule out PID. And examination, skin is very, very important. Always examine the skin of the child, complete blood count showing lymphopenia or neutropenia, then do the immunoglobulin levels, lymphocyte subset analysis by flow cytometry, CD4, CD8, and NK cells and B cell numbers, serum ferritin, easy to do, triglycerides, dihydrorhodamine assay for CGD, CH50 for complement, NGS for mutations to pick up various primary immunodeficiency. In early diagnosis, early referral can lead to great outcomes. Nowadays, I have transplanted at least 6 SCID patients with 100% success because the pediatrician referred at 2 months, 3 months of age without major infection. Previously, they were coming very late. Like 10 years back, they were coming with bad pneumonias and on ventilator, and then we are thinking, oh, to transplant or not to transplant. So we'll finish here. I'll thank all the people who have contributed to this presentation and all the panelists. Thank you. Did we finish before?
Thank you, sir, for that insightful discussion. Our next talk is on approach to a bleeding patient by Dr. Shashikant Apte, Director and Hematologist at Sahyadri Hospital, Pune. Over to you, sir.
So at the outset, let me thank Dr. Ganesh for inviting me to give this lecture. I'll use this. So at the outset, let me thank Dr. Ganesh and Yashoda Hospital for inviting me to give this lecture. A bleeding patient is a nightmare. In our country, we have a lot of congenital bleeding disorders which are not diagnosed, and patient may straightway land up on a surgical table, and post-op, the bleeding would not stop. Or it could be acquired defect. We must understand that hemostasis occurs at these 5 levels: blood vessels, platelets, coagulation factors, inhibitors, and fibrinolytic system. We can identify where the defect lies on a good history. And it is very important that when we are seeing a bleeding patient, we have to decipher, is it a congenital disorder or an acquired disorder or a combination? A person with known congenital bleeding disorder can have an acquired cause. I'll give a simple example. A person, 20-year-old severe hemophilia, had bled in joints n number of times, suddenly presented with massive melena. Don't blame hemophilia for this kind of a bleed. He turned out to have a gastric ulcer which was bleeding. A person with congenital disorder, if you miss an acquired cause, you will be wasting resources and the person would worsen very rapidly. In our country, a lot of times there are a lot of drugs available across the counter. And whenever we are seeing a bleeding patient, we have to take a detailed history for this drug history of any alternative medicines as well as even allopathic medicines. Pregnancy and neonate create a complete different issue because of the different ranges. So there are certain key points that have to be kept in mind. A mild congenital disorder may be picked up late in life. Recently, we had a 70-year-old man, never bled, came with chest pain, baseline EPDT was prolonged, and he turned out to have a mild factor IX deficiency. He had never been diagnosed with hemophilia B. Always take a family history. If there is a family history, it's more likely that you are dealing with a congenital bleeding disorder. If in a family history the female is involved, it is a bit unlikely that this is going to be hemophilia. It is going to be either a platelet disorder or a von Willebrand disease or some other rare bleeding disorder. We must keep in mind that when we are dealing with bleeding patient, sometimes the reference comes to us where the patient is already been infused with 6 bags of FFP. 5 bags of cryo. We can't do anything. We won't get the correct answer. Still we try to do it, and if there is a family member involved, we like to evaluate the family member rather with this patient, and that may give us a clue. When a person with these kind of a joints walks into your OPD, you know that this is a hemophilic patient. Whether hemophilia A or B, that will be deciphered by the investigations. So history is very, very crucial in deciphering bleeding disorders. A site of bleeding gives us a clue. If it's a joint or muscle hematomas, then it is more likely to be factor 8 or factor 9 deficiency. And mucocutaneous bleeding points us to the direction of platelet disorders or von Willebrand disease. If there is an unprovoked bleed, it straightway tells me that it's a severe deficiency. A recurrent unprovoked bleeds may be factor 10 deficiency, may be factor 8 deficiency, but it tells us that it's a severe form. As I already said, that a female symptomatic member is there in the family, it is unlikely to be a hemophilia, because hemophilia is an X-linked disorder, so females are carriers and males are the patients. If person has undergone a significant or a major surgery in the past without a major bleeding episode, it is unlikely that he has a congenital bleeding disorder. Also take a history for medical problems where there is a hepatic issues or renal issues. In history, this ISTH bleeding assessment tool is very important. These are the 14 parameters. They are easily available, and whenever we see the patient, we take a printout from the internet and we fill the scores. Each parameter is scored from 0 to 4. And these are the interpretations. In normal male, if your ISTH score is less than 3, it is unlikely to have a bleeding disorder. In female, it is 0 to 5 is the normal range. If it is more than 6, it is definitive of a bleeding disorder. And in a child, the score should be less than 2. But there is a caveat that ISTH bad score is not that sensitive in a pediatric age group, because there are certain variations in pediatric age group. So when we see these patients, we order these baseline tests, and these are the coagulation tests. Bleeding time is a very important test when you are evaluating a bleeding disorder. Please do not use bleeding time, clotting time as a pre-op workup. Pre-operative workup, it is not correct way to do BTCT because it doesn't correlate. But a child has presented with bleeding history, there is a family history, because everybody cannot do the platelet function test or may not have the access to platelet function test. A bleeding time gives us a clue. And in our institute, bleeding time is either done by the consultant or by a senior technician. And it can help with a patient with bleeding history. So if only bleeding time is prolonged among your coagulation tests, you are dealing with platelet disorders. And in India, Glanzmann's thrombasthenia is fairly common. In our own center, we have 70 patients of Glanzmann's registered, because in Maharashtra, uncle-niece marriages are quite common. And with that background, if you have a history of consanguinity and only bleeding time is prolonged, we do have flow cytometry and we confirm the diagnosis on flow cytometry, and we do the genetic testing. If only prothrombin time is prolonged, then it is factor 7 deficiency. And let me tell you, in certain parts of the world, even in certain parts of the country, factor 7 deficiency is fairly common. Many times they are asymptomatic, but they have lower levels and they can land up in trouble when they are taken for surgeries. When only APDT is prolonged, then we are dealing with factor 8, factor 9 or factor 11 deficiency. Today we do not consider the cascade algorithm for the coagulation. Like when I was a medical student, APDT prolonged used to be factor 8, factor 9, 11 or 12 deficiency. Factor 12 deficiency does not cause bleeding. It is a thrombotic disorder than the bleeding disorder. Though it prolongs APDT, they don't bleed. And again, factor 12 deficiency is not uncommon. Many times we get a call in the evening of a pre-op day that APDT is 70 seconds. You take a detailed history, patient has never bled. you straightway order for factor 12 assay and within 2 hours you have the diagnosis. Factor 12 deficiencies do not bleed, do not worry about APTT prolongation. And we always do correction studies, we do factor assays, and we do inhibitor screening. When it is both prothrombin time and APTT is prolonged, we are dealing with a common pathway, and we are dealing probably with we are probably dealing with factor 10, 5, 2, and 1 deficiency. A dysfibrinogenemia, again, is fairly common. Dysfibrinogenemia or factor 1 deficiencies, generally there will be a history of excessive bleeding when the umbilical stump falls off. Take that history in a child or even in adult, if there is a significant bleeding history. When all screening tests are normal, where are we left with? Most common diagnosis is factor 13 deficiency. If all your history is suggestive of a bleeding disorder, all screening tests are normal, you're dealing probably with factor 13 deficiency or some type 1 and type 2 von Willebrand disease. Sometimes a mild factor deficiency can give a normalization of APTT. So it is a big topic how to select the PT and APTT reagents. I won't go into the details of that, but there are reagents which are factor insensitive, and you may get a normal APTT with a mild deficiency of factor 8 or 9. Then we do these additional tests. That 5 molar urea solubility is a good screening test for factor 13 deficiency. Then we do platelet aggregation studies, we do von Willebrand workup, we do flow cytometry and DNA studies. Flow cytometry is an excellent tool for a lot of bleeding disorders, which is unexplored in our country to that extent. But it's a very good tool if you have a backup, and luckily we have a backup of an excellent flow cytometry for our platelet disorders. When we have known hemophilia, patient is bleeding, and the bleeding has not stopped with adequate factor replacement, and these are not uncommon situations. Many a times inhibitor is missed. Coagulation protein inhibitor is very, very complex situation and difficult situation to manage. So you have to, whenever we take patients of major surgeries, we always do the inhibitor testing and make sure there is no inhibitor before taking the patient for a major surgery. We always have to rule out a surgical cause, and we have to rule out an acquired defect. We had 2 mild hemophilics who had never bled, and they suddenly came with a spontaneous bleeding. They are our own patients, factor levels in the range of 20-25%. When they came bleeding, and actually when we did APTT was beyond 100 seconds, and factor level had dropped down to less than 1%. So they had become a severe hemophilics. What had happened? They had developed an acquired inhibitor. And both of them turned to have a malignancy in the system, and this malignancy was causing the inhibitor development. When we see a female with APTT prolonged, we know that APTT prolongation in female, most common cause is actually lupus anticoagulant. Lupus anticoagulant is a thrombotic disorder. Sometimes we can get female with APTT prolonged, and you can have the various situations like 45XO, Turner's syndrome is one of the causes that you can get a female hemophilic. But it is more likely that it is going to be factor 11 deficiency, factor 12 deficiency, or type 2M von Willebrand disease. Neonate or an infant, we have to keep in mind the reference ranges are separate or they are different. 45 seconds APTT in a 2-month child is normal. Do not chase that up. Do not chase that up. It is a normal APTT for that given age. It is important that we have these references available with us before we make the final interpretation. We always evaluate a mother when a neonate comes, because there could be a maternal problem which is being passed on to the child. And many a times you may need a repeat testing. When a child presents with a bleeding manifestation, please do not do the femoral puncture to do the blood collection. If child has a severe form, he will have a big hematoma and child can succumb. Always call in the expert to collect the samples because you need a good sample, and sometimes it is better to do a radial artery collection in a neonate or a small child rather than doing a femoral puncture where we are suspecting a bleeding disorder. It is very crucial to know the diagnosis because when they come in emergency, it is easier to tackle them. Now the patient is presenting with a bleed, there is no past history of bleeding. Again, we have to see whether it is a spontaneous or provoked bleed. Is he on any drugs? Is he a stable clinical condition or has a preceding illness? And is it, especially in a female, is it a pregnancy antepartum or it is a postpartum situation? Low platelet count is the commonest situation in acquired condition. Many times, platelet counts can be low platelet counts can be transient, especially in a viral episode. Do not treat the platelet count. If the patient is bleeding and platelet count is above 50,000, do not blame that platelet count for as a cause of bleeding. You have to evaluate these patients. And don't try to treat the platelet count. If the platelet count, you accidentally, you are doing a workup and platelet count is 40,000. Wait, repeat it. Don't chase on the first day if hemoglobin and WBCs are normal. But also keep in mind that every thrombocytopenia is not ITP. So most dreadful situation is DIC, hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura. These three diseases comprise of a condition called as MAHA, microangiopathic hemolytic anemia. Dr. Tulika showed one of the slides of MAHA. Basically, it happens because of the vascular endothelial injury, small vessel thrombosis, and ischemia of end organ. And we have to keep in mind that in DIC, the manifestation is bleeding, but the pathophysiology is thrombotic. It's a thrombotic disorder, not presenting as a bleeding. So when we are suspecting there is a scoring system for overt DIC, so first as situation you find out, is the given clinical situation lead to DIC? If the answer is yes, go ahead and you get this kind of a score. The first thing, if the situation is not known to cause DIC, you go to no and you stop there. TTP HUS has to have a very good area of suspicion. PBS is diagnostic with high LDH, and generally PT-APTT is normal. Whereas in DIC, you will have low platelets and PT-APTT abnormal. Patients on drugs, like today elderly patients can on multiple drugs. You have to take care of detailed history of drug and act accordingly. So general principle in tackling bleeding complication, always rule out a structural cause. You must know what is the half-life of the drug that the patient is taking. And you must keep in mind, is the bleeding occurring in a therapeutic range? Like suppose somebody is on warfarin, INR is 2.5, presents with spontaneous bleed, don't blame that INR. Rule out a structural cause. And because he is on warfarin, there will be more bleeding. But the cause of bleeding may not be the warfarin in a therapeutic range. And try to find out if there is an antidote available. And in a bleeding patient, activated Novo-7 is one of the great drugs to use in emergency. It virtually tackles all sorts of bleeding situations. And this is how the algorithm is maintained. When you are treating a bleeding patient, you have to maintain hemoglobin above 10, use FFP cryoprecipitate, do at least daily hemogram PT-APTT, thrombin time and fibrinogen, and keep fibrinogen levels above 150 DL, and keep platelets above 50,000 per cm. So major causes of bleeding while on drugs is the wrong selection of a drug. There is a wrong combination. There is a wrong dosages, and there is a missed underlying medical or surgical cause. And most important, unreliable reports. So I'll just have a couple of cases. We had these two brothers referred with gum bleeding and nasal bleed at age of 2 and 4. And there was also a history of congenital deafness. We were wondering what the hell it is. And when we took a blood pressure, always take a blood pressure and do the primary examination of the patient. One child had BP of 220 by 120. Other child had BP of 220 by 140. The diagnosis was straight Alport's disease. We got the creatinine done, and it was 9.9 and 11.2. In both the children, renal biopsies were done. It confirmed the diagnosis of Alport's disease. The elder child is surviving after a renal transplant from the mother. The other child died of an IC bleed. So this was a pediatric children, two children involved from same family, consanguinity there. It was not a bleeding disorder. It was something else leading to bleeding. Second case is 69-year-old female, mother of a medical person, had an air journey from US back to India, developed DVT, systemic thrombolysis was done by RTPA. This patient could have been very easily treated with LMWH followed by oral anticoagulation for 6 months. Within 12 hours after using systemic thrombolysis, the lady had massive intraperitoneal bleed, was in shock. We had to put in a filter. We had to stop anticoagulation in therapeutic range. It was a nightmare. And this was the wrong selection of a drug while treating the person. And this is the last case. It was a road traffic accident. It was a compound fracture, happened in periphery of Pune on day of Diwali. And this was the workup. Patient was infused, operated, and referred to us because bleeding won't stop. And this was the CT scan when he came. He had gas gangrene post-op and post-injury. You can see the gas in the muscle mass. He underwent the emergency amputation. We made a diagnosis of factor VIII deficiency. He is doing well now with the prosthetic limb. But on date 11, while the things were settling down, he suddenly bled. And we did an angio, and there was an aneurysm of the femoral artery. And we embolized that aneurysm part, and the bleeding stopped. So coagulation laboratory is very important. This laboratory has to give you rapid and reliable reporting if you want to tackle bleeding patient. Have a dialogue with your coagulation lab. Make sure they are maintaining certain internal quality assurance programs and participating in some external quality assurance program. So to conclude, I would say that if you have your team ready, you can tackle a bleeding situation very confidently and successfully. Lab plays a very, very important role, and there has to be a good dialogue between a clinician and a lab, especially in this situation. I would thank you all for kind attention, and I would like to take any questions if you have. Thank you. Can you give a mic to him?
Morning, Dr. Apte. I am a pathologist. Any bleeding patient, is it, if we do basic like a platelet count and then prothrombin time and APTT, that is enough?
I think so. With a good history, these three things are enough. That's why I showed the I stage bad score. All our patients, our anesthetists are trained on a pre-anesthesia checkup. They calculate the I stage bad score. And if I stage bad score is in the given range, just with normal platelet count, normal PT, normal APTT, you can take the person for any surgery or you can decipher. But if there is a history, and we always do have an algorithm that whenever we are seeing a bleeding patient, we collect 2 extra citrate bulbs, we separate the plasma and freeze the plasma at -80. Because then the clinicians are very free to do infusing cryo, infusing FFPs till we get the answer. But if the history is not significant, platelet count, PT and APTT is good enough. But APTT also has to be done. A lot of people just do hemogram, platelet and PT. APTT is not done. But I agree, these three things are enough.
Yeah, because platelet, BT and CT, what we are doing in our lab, is just a very crude method.
No, I would not do BT-CT unless I am evaluating a bleeding patient or a congenital bleeding disorder. I will not do bleeding time, clotting time as a, what I should say, a pre-op evaluation. Person is undergoing surgery, we will not do BTCT. We'll take the ISTH bad score, we'll do platelet count, we'll do PT, we'll do APTT. That's it. If there are no questions, thank you all again. Thank you, Ganesh.
Thank you, sir, for that informative session. Next, we move on to our next session on sickle cell disease management in 2025. I would like to invite Dr. Gaurav Kharia, pediatric hematologist and BMT specialist, Apollo Hospital, Delhi. Over to you.
Good morning, everyone, and once again, thank you, Ganesh, for having all of us here. So it's an opportunity to meet our learned colleagues and also to sort of have a social gathering with them. So thank you once again, Ganesh, for this wonderful meeting. I've been tasked to talk about management of sickle cell disease in 2025 and beyond. So this is a quick overview of today's presentation. So we look at sickle cell disease burden, pathophysiology. We'll briefly dwell into the history because it's always very interesting and intriguing and also paves the way for future developments in that particular disease. Current therapeutic modalities, transplant, what is the background, what are the challenges, what is our experience, why do we need something beyond transplants, a quick word about gene therapy, and finally we'll sum up and move on to the question answer session. So if we talk about the burden of red cell disorders, so this slide shows us basically both, we know that thalassemia and sickle cell disease, these two are the commonest red cell disorders across the globe. If we just talk about sickle cell disease, approximately 30 to 40,000 patients are born every year in our country. And if you look at the global figures, approximately 300,000, 400,000 patients are born globally every year with sickle cell disease. So it's a huge clinical burden in today's day and age. If we talk about the pathophysiology, we know that it's a point mutation which leads to defective sort of formation of mRNA, which in turn leads to defective formation of protein. And this protein is prone to polymerization in sort of hypoxic environments. And once it polymerizes, it gives this typical sickle shape to the red blood cells. And then subsequently, it leads to either hemolytic manifestations or vaso-occlusive manifestations, which are the hallmark of this particular disease. Dwelling into the history, like this is not a very old disease. So the first sort of report of sickle cell disease comes from 1910 when this physician in US, Dr. James Hendrick, he noticed some very weird findings of in peripheral smear of one of his medical students who happened to be someone from African origin. So at that time, he thought that probably it's some reaction to a drug which is leading to this particular abnormality in the peripheral smear. So he repeated it multiple times, and every time he got the same finding. And that is when he proposed that probably it is something new which he has discovered. Subsequently, a lot of work was done, and in 1948, 1950, Dr. Linus Pauling, who is a famous chemical biologist in the US, he proposed this new entity which is molecular structure of sickle cell disease. Further, in the same year, Dr. V.S. Ingram differentiated the molecular structure of sickle cell disease with respect to other hemoglobin variants. So as this work was going on, a very astute and observant pediatrician working in Brooklyn, New York at that point of time, made a very sort of significant observation that the kids who are born to mother with sickle cell disease and eventually develop sickle cell disease, in the initial years of life or initial period of life, they are protected against sickle-related manifestation. And that point of time, she attributed some presence of say, hemoglobin in these patients in the initial period, and which protects them from these sickle-related manifestations. This was further proved by a large-scale study by Ora Platt published in NEJM, where in a cohort of around 15,000 patients, they documented that the fetal hemoglobin is more than 8.6%. These patients are relatively protected against the manifestation of sickle cell disease as compared to patients who have a fetal hemoglobin of less than 8.6%. Now, another significant contribution was made by this Indian sort of researcher, clinician researcher, Dr. Vijay Sankaran, works in Boston Children's Hospital. So before his work, it was not clear what is the patho or how does this transformation from embryonic to fetal to adult hemoglobin happens. Okay, so his work put a significant light on this transformation, and not only this, he also highlighted the importance of some important molecular markers which now people are exploring to exploiting to sort of treat both the sickle cell disease and thalassemia with respect to gene therapy. Now, we all know that the burden of the disease, sickle cell disease, is maximum in parts of the world which are endemic for malaria, and the reasons for this are pretty obvious. Looking at how the landscape of the disease burden will evolve. So as per WHO estimates, even if we start making full-on efforts, then also the disease burden will only plateau after 2050. So we are still a long way to go, and that's why we need to talk about this disease and make significant contributions both in prevention and treatment of sickle cell disease. Now, when we talk about the current treatment approaches, so this is how the treatment chart looks like. So we have hydroxyurea, which all of us know is a significant, is a very important drug for these patients. Then L-glutamine, Voxeltor, crizanlizumab, and when we talk about curative therapy, it is bone marrow transplant, awaiting a wider application of gene therapy. Now, hydroxyurea, I think all of us know the role of hydroxyurea in sickle cell disease. It works by multiple mechanisms. These were the initial studies which very clearly documented that if you start the patient on hydroxyurea, it reduces the symptomatology quite significantly, and also to some extent change the course of disease. It can also, this Hughes-Soft study showed that if a patient who is already affected with sickle cell disease, if we introduce hydroxyurea, it can reverse the course of the disease as well. So a very important drug, and all the patients who are diagnosed with sickle cell disease should be started on hydroxyurea. Other important thing was what is the right time to start hydroxyurea. So initially it was more than 2 years of age, but the patients before 2 years of age were also very symptomatic. So this baby hug trial was done to see the safety and efficacy of introducing it at early years of life. So baby hug trial, it was a phase 3 multicentric trial to look at the efficacy of hydroxyurea between 9 to 18 months of age. 193 subjects were included. 20 milligrams per kg of dose was given. Overall, they were observed for 2 years, so 374 patient years on study observation. Hydroxyurea was found to be associated with lower rates of pain, dactylitis, acute chest syndrome, so all the complications related to sickle cell disease, and there was no increase in myelosuppression or infective complications. So again, it proved that it is not only 2 years, it can be introduced as early as 9 months, and now people start introducing it as early as 6 months of age, or as soon as the diagnosis is made. Now, this was again a very interesting and important trial, which is a HOPE trial looking at the effect of Voxeltor. So we know that sickle cell disease is because of this hemoglobin protein polymerization. So Voxeltor is a HbS polymerization inhibitor. This was a phase 3 double-blind trial to assess the effect of Voxeltor in 2 different combinations as compared to placebo. So 1500 mg, 900 mg versus placebo. Primary endpoint was to documented increase in 1 gram per deciliter of hemoglobin from the baseline at 24 weeks. 274 patients were randomly assigned in 1:1:1 ratio. 51% patients in 1500 mg cohort of Voxeltor showed desired increase in hemoglobin vis-a-vis 7% patients in the placebo cohort. And they all had a similar adverse effect profile. So important drug, but unfortunately did not change the course of the disease, only brought down the symptomatology. Next, SUSTAIN trial, another very important drug, crizanlizumab. So we know that in pathophysiology of sickle cell disease, the vaso-occlusive episodes, P-selectin upregulation plays a significant role. So crizanlizumab is a P-selectin inhibitor. Okay, so the objective was, or the thought was, that if we can downregulate the P-selectin, the cell to endothelial surface interactions can be reduced, and that is how the cohesiveness or the veno-occlusive episodes can be prevented. So crizan is an antibody against the P-selectin. It was a double-blind randomized phase 2 trial receiving for patients receiving 2.5 mg per kg or 5 mg per kg or placebo 14 times over 52 weeks. Primary endpoint was reduction in veno-occlusive episodes. 198 patients were randomized. The effects was 1.63 VOC was seen per year VOC was seen in Crazan 5 mg per kg. Vis-a-vis 2.98 in placebo group. So it did decrease the incidence of VOC and also the time to first or second crisis. But unfortunately, this drug did not stood the test of the time, and eventually it was withdrawn from majority of the international markets. Now, these were the 3 drugs. So apart from these, there are other drugs like L-glutamine, which play some role, but these were the 3 drugs which have been tested, and out of which I can very confidently say there's still hydroxyurea is the one which has stood test of the time and is one sort of wonder drug for patients with sickle cell disease. Now, moving on to curative approaches, so which is transplant and gene therapy. So this was the first publication documenting the role of transplant in sickle cell disease. So this was acute myeloid leukemia child, also had a patient also had a sickle cell disease. So underwent a transplant for acute myeloid leukemia and eventually was cured of both acute myeloid leukemia and sickle cell disease. So this paved the way for this thought that transplant can cure sickle cell disease per se. Sickle cell disease transplant is an unmet need. There is a huge burden. We have already seen almost 400,000 patients, new patients are born every year. And I would say still this might be sort of an understated figure because majority of places there's no registry. So in Africa or India, there's no formal registry. So this number might even be higher. Every year we do around 100,000 transplants globally. But if we look at the number of transplants for sickle cell disease offered right from the beginning, so in past 3 to 4 decades, it is just sort of 2,500 to 3,000. So 100,000 transplants every year vis-a-vis around 3,000 transplants in past 4 decades. So there is a significant lag in transplants for sickle cell disease. Why is this difference? What are the factors responsible? So based on my understanding and work in sickle cell disease domain for almost 1.5 to 2 decades, this is what I have realized. Lack of clear-cut indications for transplant, lack of awareness, information amongst physicians, parents and patients, lack of funds, which even becomes more important in our country and other parts of the world such as Africa, lack of availability of suitable donors. This has been addressed to significant extent by availability of haploidentical transplants. Now, if we talk about the indications, so this is one set of indications which I feel is the most appropriate, and this was used by the NIH group. And if we look at these indications carefully, every 3rd patient in India also fulfills one of the criteria for transplant in the initial years of life. And subsequent later, as we move ahead, the number of patients fulfilling one of these criteria increases. Now this was one meta-analysis done by CIBMTR to look at the outcomes of transplants for sickle cell disease. So altogether 1,400 patients were enrolled, out of which 910 was sort of chiseled out, and out of these around 550 were matched sibling donor, around 150 were haploidentical transplants, rest were matched or mismatched donor transplants. And one thing which was evident was that the outcome of haploidentical transplant or unrelated donor transplant was inferior. Sibling donor transplants was pretty obvious. So if we have a child, so out of 100 patients who are suffering from sickle cell disease, only 10 to 15% have a sibling donor. Rest 85% do not have a matched sibling donor. And the only option available with us is to use an alternate donor, and an alternate donor, haploidentical transplant. So there was a felt need to optimize the strategies for haploidentical transplant. So while I was working at St. Mary's, we made some modifications in the initial strategy used by NIH group. So NIH group documented that yes, haploidentical transplant can successfully be done for sickle cell disease, but in the initial approach, the overall survival was 100%, but the event-free survival was just 56%. So 46%, 44% patients had a graft failure. So we optimized this strategy at St. Mary's, and we showed significant improvement. Then the graft failure came down by almost 10 to 15%. So the overall survival and event-free survival was approximately 85 to 90%. So with this thought, I came back and started working in sickle cell disease, and started using the same approach, but very soon I realized that it is not going to work here. So we optimized our protocol, and finally we came to this Apollo protocol. We initially treated our sort of 25 patients using this protocol, had significant sort of outcomes, very low GVHD rates, and overall survival was approximately 88 to 90% in this very, very high risk cohort of patients. So the patients were from 2 years of age to around 24, 25 years of age, very, very symptomatic patients. And if we can offer a haploidentical transplant outcome of approximately 90% in these very symptomatic patients, it was a great achievement. This is our overall experience till June 2025. Apologies, this is a little bit old data, but around 123 patients who were treated by that time. This is the age group, so 10 months till 32 years of age. Almost 50% underwent a sibling donor transplant, 50% underwent a haploidentical transplant. Again, if we look at the salient features, so we have evolved over a period of time. So if we look at the outcomes before 2019, the outcomes were a little bit inferior, and beyond 2019, if we have a sibling donor less than 13 years of age, the outcome is approximately 98%. If we have a haploidentical transplant less than 18 years, less than 13 years of age, still the outcomes are approximately 93 to 94%. So age matters, makes a significant difference beyond 13 years of age. Because of one or other underlying damage, organ toxicity, the outcome of transplant goes down. Acute GVHD rates and chronic GVHD rates have also come down significantly. So with respect to transplant, our overall learning is transplant, HLA identical donor transplant is the preferred source. Success of haploidentical donor transplant is also increasing. Now, with respect to sickle cell disease, the algorithm is a little bit different. If you have a sibling donor, go to sibling donor. But if you don't have a sibling donor, don't waste time in unrelated donor transplant. You can directly go to haploidentical transplant with equal or better outcomes as compared to unrelated donor transplant. We have almost 100% addressed the risk of graft failure. We do not see any graft failure now even in haploidentical donor transplants. GVHD rates have come down significantly. Based on our observation, age plays a significant role, so early intervention gives you the best results. So take the patients less than 13 years of age, in contrast to the previous thought that we should take up these patients only when they are very, very symptomatic. Infections are still a challenge, but we are trying to address them. And as we move ahead, we are trying to further optimize. So now we have modified this protocol further for patients beyond 13 years of age. And with that protocol, we are seeing that we are getting, even beyond 13 years of age, we are getting very, very good outcomes. So to whom to transplant and when? This is a very sort of broad way of understanding it. As in any non-malignant disease, such as PID or thalassemia, for the best outcomes, transplant should be offered when the recipient has a good functional baseline in anticipation of the inevitable organ damage that is driven by the duration of pathology and thus the age. So the key point to remember is that early intervention is definitely. One organ involvement brings down the success rate by 10%. Two organ involvement brings down the success rate by approximately 25 to 30%. Now switching gears, moving on to some futuristic therapy, gene therapy, which appears to be far away, but I would say not far away. Within 2 to 3 years, I'm pretty confident that we'll have something good to offer for our patients in need as well. Now, why do we need anything beyond transplant? Even after all the advances in conditioning and supportive care, still there is morbidity and mortality associated with transplant. The donor pool is limited, but that has been addressed to a significant extent by alternate donor transplant. Age is still a barrier, as I highlighted. So beyond 13 years of age is a very challenging group. Monogenic mutation, sickle being a monogenic mutation, is an interesting target for gene therapy or gene manipulation strategy. Now again, I would like to highlight just quickly on the observation made by Janet Watson that the fetal hemoglobin plays a very, very important role, and also to the work done by Vijay Sankran, which showed that how can we sort of optimize or increase the level of fetal hemoglobin to have the desired effect in thalassemia and sickle cell disease. Now, this is how the fetal, the hemoglobin switch happens. There is a locus control region, and as the locus control region moves ahead, it attaches to hemoglobin E locus or fetal hemoglobin locus, and in adult life to the adult hemoglobin locus. Now, if we somehow disrupt this locus, we can force the locus control region to attach to the fetal hemoglobin locus and produce more fetal hemoglobin. Okay. Now you might think, how is it going to help? So we all know that there is an entity called as hereditary persistence of fetal hemoglobin, which is a very common entity. So in these patients, the fetal hemoglobin is around 40%, 50%, 60%, and they are completely asymptomatic in the entire life. So this is what people are trying to do, that by doing this disruption using either lentiviral vector or genome editing, we are trying to sort of simulate hereditary persistence of fetal hemoglobin. So using this strategy, one patient was treated using a lentiviral vector for sickle cell disease, and this patient did very well. We can see here that the hemoglobin levels increased from 30% to almost 60%. But there were some challenges, and we all know that in this particular study done by Bluebird Bio, around 5 patients of sickle cell disease either developed myelodysplastic syndrome or acute myeloid leukemia. So unfortunately, they got approval for thalassemia, but not for sickle cell disease so far. So there are some challenges with lentiviral vector mediated approaches, especially for sickle cell disease, and that's why another important, interesting approach is a genome editing. Okay, genome editing, what is it? Using one of the available tools such as CRISPR-Cas9 to make desired changes in the genome. Okay, so this is what we intend to do. These are the various genetic tools. The most in use is the CRISPR-Cas9 approach. And using this particular approach, the first patient of thalassemia and sickle cell disease was treated. This again was published in NEJM in 2020. Subsequently, around 70 patients have been treated in both cohort, thalassemia and sickle cell disease, with 100% overall survival and almost 98% response rate. So 98% patients, both in thalassemia and sickle cohort, are asymptomatic using this genome editing by inducing the fetal hemoglobin. So to conclude, sickle cell disease is a preventable disease. As soon as the diagnosis is made, which is usually in the first year of life, supportive treatment should be initiated as soon as possible. A close observation is required to identify severe phenotypes of sickle cell disease, and they should be taken up for transplant in early years of life to have the best outcomes. BMT should be offered to these severe sickle phenotypes in early years of life. And as we make transplant more amenable to the masses, we should also prepare ourselves for future modalities such as gene therapy or genome editing. So with this, I would like to thank you all for a very patient listening, and thank you, Ganesh, for having us here, and I'm happy to take any questions. Yes, please. Can someone hand over the mic there?
So Dr. Gaurav,
Sir.
This sickle cell disease, how rampant is there in India?
Very rampant, sir. Very rampant. So I showed the figure, around 30,000 to 40,000 patients are born every year, even till date, I mean in 2025 also, with sickle cell disease, and that is why PMO has taken this initiative of eliminating sickle cell disease by 2047. So that shows the prevalence of the disease and the focus of government to eliminate sickle cell disease.
Because as if now I know that in Middle East and African continent, you have a lot of cases of sickle cell.
So 3 countries put together, Nigeria, Congo and India, forms 33% of the sickle population of the entire world.
So those patients from other countries, do they come to Delhi for bone marrow transplant?
Almost till last year, almost 95% of our patients were international patients. But with the increased awareness, with a lot of support coming in from the state governments and also the central government, now almost now a significant chunk of patients are Indian patients. So at this point of time, we have around 8 patients currently admitted with us from India for sickle cell disease.
Okay, thank you very much.
Thank you, sir.
Gaurav, excellent talk. So as we are aware that for thalassemia, there is a huge advocacy and there are various NGOs which are working for thalassemia. It's very visible. And there is a Coal India program where Government of India is giving 10 lakh rupees for bone marrow transplant for poor patients suffering from thalassemia across India. But sickle population is tribal population. They are silent. They don't have NGOs. There is no visibility. And Coal India, all the coal is produced in the sickle tribal areas.
True.
And there is no support for sickle. Is this going to change ever in India?
So that's going to change very near future. So Dr. Tuleka is also here, and I think there is a strong advocacy now to change this. And the first step which is taken, which has already been taken, is the focus which PMO has brought to sickle cell disease by this 2047 sickle cell disease elimination mission. So that shows that there is commitment, there is will from central government, which is now translating into state government also. So state government support is just phenomenal nowadays, and they support almost 90 to 100% of the transplant cost. But for larger group of patients, I think Quality is also thinking of including sickle cell disease. So it's just a matter of time. They will also get the necessary support. And with this, we'll be able to help much more patients in need.
Thank you so much, Dr. Korav. I'm Dr. Dung from Uganda, and thank you for supporting people from my country. You know, I always get this question. Doctor, we have a child with sickle cell. Would you recommend a transplant? And of course, the answers are mixed. And then my question is, with your experience, patients who have undergone transplant, vis-a-vis those who have not undergone transplant, what is their quality of life post-transplant?
So post-transplant quality of life, I mean, the time was short, unfortunately, so we could not touch that aspect, but we presented this data in EBMT, I think last year, assessing the quality of life. No, it was not. It was not EBMT. It was ASH this year, where we presented the quality of life data, and there is a significant improvement in quality of life post-transplant vis-a-vis pre-transplant. So I can share the abstract with you. We sent it to ASH this year. So there's no doubt. I mean, the entire, not only the quality of life of the child, but the quality of life of the entire family improves post-transplant. But Dr. John, you have witnessed the scenario in Uganda, and I think it's no different in other resource limited setting. I would say in India also in various parts. So what we need to understand is that these patients need to be taken up for transplant in early years of life. The outcomes are 20%, they straightforward come down if the patient moves beyond. And this 13 figure of cutoff of 13 is for European patients and American patients. If we translate it into resource limited setting, India and in Africa, this number comes down to less than 10 years. If we have a patient less than 10 years, irrespective of what transplant we do, we confidently say that the outcome is going to be 95, 96%. Beyond that, the outcomes go down significantly.
Good morning, sir.
I have one question.
Good morning, sir.
Oh, sorry. Okay.
Yes, please.
Okay. I have one, actually two-part question. First of all, thank you so much. I come from a company which makes point-of-care confirmatory tests for at 36 weeks gestation. So we can screen for newborns quantitatively. So my question comes to that. It comes to, you said you can transplant below 8 years. So I'm asking what's the earliest you can transplant? That's number one. Number two, since it's a tribal disease, people can't afford, how do affluential institutions like you, hospitals like Apollo, actually help the rural and tribal population get this transplant, because it is unaffordable for them?
Right. So both are very pertinent things. So if you talk about the age, so in my cohort, the earliest patient whom we transplanted, youngest was 10 months of age. Okay, and this patient had a significant sickle-related life-threatening complication in 6 months of life. Subsequently, we did the screening, sibling was a match, so we did not waste any time and we took him up for transplant at early months. This child is more than 8 years, 9 years post-transplant, doing extremely well. Second thing is, what support is coming from the corporate hospital? I think it's not about only about Apollo. It's in general, whether it's Apollo or Yashoda or Medanta, for these sort of chronic ailments, there is support which comes in from government. Government, I have already told you, state and central governments, but hospitals also contribute in whatever way they can. The rates, I mean, altogether are very different. So I would say the cost of transplant, which for other disease might be around, say, 18 to 20 lakhs, for such chronic disease, sickle and thal, it turns out to be around 14 to 15 lakhs, so almost 25 to 30%, and that's because of the help which is extended by the corporate hospitals.
Good morning, sir. Sir, sir, here. Good morning,
yes,
sir.
Yes, please.
15 kg child, sir, with sickle cell disease. So we have to give 20 mg per kg, 300 mg. So hydroxyurea tablet is available in 500 tablets.
Yeah.
So how should I?
Yeah. So we just sort of the dose is 20 to 30 milligrams per kg. You can round it off. That's a big challenge. So again, we have been trying to address this, and I think one company has already come up with a syrup although the purpose is defeated because the cost of the syrup is 1500 rupees, so which just defeats the purpose. But yes, 250 milligram tablets will also come very soon. The problem is that majority of the formulations are presently in encapsulated forms. There are, I think, 1 or 2 formulations which come in scored tablets. So you can look for those scored tablets, and scored tablets can be split and can be given. Syrup, I'm sure other companies will also follow the suit, and maybe in a year or two we'll have a solution for this particular thing. Thank you.
Thank you, Dr. Gaurav. I request all the speakers, chairperson and panelists to collect mementos at the podium near photo booth. I request all the speakers, chairpersons and panelists to collect mementos at the podium near photo booth. Next, for our panel discussion on decoding anemia, I would like to invite our moderator, Dr. Uday Yanmandra, hematologist in Armed Forces Medical College, Pune, and our panelist, Dr. Abhijit, Hemato-Oncologist, Kolhapur, Maharashtra, Dr. Girish Badarke, Senior Consultant Hematologist and BMT Physician, SMBT Charitable Hospital, Dr. Vikas Goel, Hematologist and BMT Expert, Tikaparna, Dr. Ashay Karpe, Medical Oncologist, Sunrise Hospital, Mumbai, Dr. Avinash Singh, Hematologist and Oncologist, Patna Parvaz, HMRI Patna, Dr. Katara Sudhir Reddy, Medical Oncologist in Gayatri Estates, Kurnool, Dr. Vamshi Krishna Reddy, Medical Oncologist, Yashoda Hospital, Hyderabad, Dr. Somnath Gupta, General Physician, Yashoda Hospital, Hitec City, Dr. Chitresh Yadav, Hematologist Oncologist, Fortis Memorial Research Institute, Dr. Saumika, Medical Oncologist, KIMS Hospital, Hyderabad. Thank you.
Good morning, ladies and gentlemen. Firstly, I would like to thank Dr. Ganesh and Yashoda Hospitals for giving us this opportunity to discuss about anemia. But many of the people who left the hall would repent their decision of not attending this session, because this happens to be one of the most difficult things for a hematologist to handle, particularly because as fever is a troubling factor for clinicians, anemia is a troubling factor for most of the benign hematologists. In a NMC course, we have 32 hours catered for anemia, so that shows the importance of this. But anyway, it's a long thing to be covered. So thankfully, Tulika ma'am had covered hemolytic anemias in the morning, and Gaurav has covered sickle cell anemia in the previous session. So we'll talk about something different, but we are going to have the lecture in a different way. We are going to have it as a dialect wherein you have to scan this code. So I request all of you to open your mobiles and kindly scan this code. Particularly for the PG residents and others, please scan it out. It will be a fun. We are going to have it in a gaming mode. You please give your answers, then the panelists will say whether you are right or wrong. And then they will give their comments, why are you right or wrong. And they are all very simple questions. They are all MBBS level questions, so nothing big. But it just tells us that how much we need to know more about it. So if you have scanned it, let's go ahead. So these are our esteemed panelists, but I think we are only 4 of us here. So anyone can take any question depending upon the comfort. There is no specific thing. So let's start off with the spotters. The first one, we have a 6-year-old male, abdominal discomfort, easy fatigability, recurrent oral bleeds. This is a photograph of the patient. He was given ERT, and post-ERT, that's the photograph of the patient. And the CBC showed severe anemia along with thrombocytopenia and neutropenia or leukopenia. So what is the diagnosis? Wow, people are too fast. Good. Fine. For those whom of you have answered it as Fabry's, Fanconi's, Falcons, I'm not aware of what Falcons is. Okay. Fine. So we go ahead with the majority where you feel that this is Gaucher's disease. So yes, this is Gaucher's, wherein your people will have growth retardation, anemia as a major manifestation, and massive organomegaly with which they come with. The first few spotters are just to understand how can anemia have a varied manifestation other than what we routinely feel as. The second spotter, a 10-year-old male short stature, microcephaly, easy fatigability, transfusion dependent, hemoglobin 4.2 with associated pancytopenia, and the examination showed these lesions on the body along with absent thumb, and this was found on the marrow. Now, what would be the diagnosis? Fine, good. This is why I like Hyderabad. People answering spontaneously. Good. I don't agree with B12. TAR is generally a problem with absent radii. It's thrombocytopenia with absent radii. The other two cell lines are not afflicted. Somebody has written TAR. Somebody have written dyskeratosis congenita. No, you are too fast in the slides. That's probably the next case. Okay, leukoplakia, no. So this is Fanconi's, and when you do the studies, the cytogenetics for these people, stress cytogenetics, so you find triradiates and tetraradiates, and these are the various clinical features. So anemia, a different manifestation in children, this. Now let's keep going higher and higher age. Now we started with 6, 10, now let's go to 11-year-old. Easy fatigability, recurrent infections, oral bleed. And on nail examination, you find these nails. On the oral cavity examination, you find this on the tongue, and you find some premature graying. So what do you feel the diagnosis? Good. So this is dyskeratosis congenita. For those of you who have answered dyskeratosis congenita previously, this is dyskeratosis congenita, wherein keratin, nail, keratin, hair, keratin, mucous membranes, and skin. So all afflicted, and these patients are prone to develop severe anemias. Okay, now let's get on to the adult patients. So a patient found to have severe anemia, pallor. On examination, tongue shows these. The first one with a blue circle, and then you have got something with the white. And after a few days, the patient develops that sort of tongue, the same patient. Diagnosis? Good. Somebody has written ball tongue. Fine. Yeah, that's actually a ball tongue. B12 deficiency, megaloblastic anemia. Megaloblastic anemia is a pathological diagnosis, but okay, B12 deficiency is what it is. Excellent. Okay, this is not a lipstick ad. So this is something where the first photograph shows some ridging in the lips, and the second one showing below the lips. These two are different. So fine. Okay, B12. This can occur, by the way, angular chelosis and stomatitis are more common in iron deficiency when compared to B12. But okay, we take B12 as well. Fine. So B12 taken. Good. Next case, a problem with females very commonly, hair fall. Some ridging on the nails and hyperpigmented knuckles. Very easy till here, don't worry. We go ahead further, and you find this on the MRI. And you find a darkish hyperintensity on the dorsal column and a V-shaped sign. This is known as V sign on the transverse section. Inverted V sign is what we know it as. So the fundus examination reveals this and that. So not only the diagnosis, I would like to know what was there on the spine and what is there on the fundus examination. It's B12 deficiency, but what was there? Knuckle hyperpigmentation, I have already said. It's not SCD, that's gorostopic. It's SACD. So this is subacute combined degeneration of the cord, and on the fundus what you saw were Roth spots. So Roth spots, all of us learn infective endocarditis. Answer is wrong. Roth spots are more common in diabetes and in severe anemia cases. So those are Roth spots. The last case, a 48-year-old male, abdominal discomfort, initially presented with leukocytosis, but now with leukopenia. Fine. So I have asked for cause of splenomegaly with anemia. Too many answers. Good. So people feel it was CML because leukocytosis was there in the beginning. Fine, that's okay. Now the same patient, if I say he was from Bihar. Excellent. So, good. Now because you have answered it well, last one more question. A 32-year-old male, persistent fever, gradually progressing anemia, followed by development of pancytopenia. So what are the cause of fever with anemia? Okay. Please remember, fever with anemia other than malaria, you have got much more commoner causes nowadays. People have written Kala Azar, malignancy, CMV, dengue. Okay, we'll discuss about that in a while. So these are all the causes of fever with anemia. So let's get on to the day's topic of how do we define anemia and how do we go ahead. So can I have one of the panelists? How do we define anemia on today's date? Anyone, sir? I'll not take names because we are only 4 of us, sir.
So basically, like anemia, we define by age and sex also. So both the things has to be considered when we define. But as a like by WHO definition, in the females, especially if the hemoglobin is less than 11.5, and in males is less than 13.5. That is what is the standard definition. But this varies again as per the geography and the males, females, and the age.
So the point is, when we define anemia, many of the textbooks or the kids also define it based on hematocrits. So your comments on that as well.
So by and large, hematocrit less than 35 is usually what we follow. But then thing is that the hematocrit depends on the multiple factors. So how to take that? That is also we need to look when we are looking at hematocrit.
Wonderful, sir. So sir said hematocrit variable. We take definitions both on both hemoglobin and hematocrit. So can I have the audience answering this? So what do you feel? Is hemoglobin better or hematocrit is better for defining anemia? Okay, fine. So the audience feel that hemoglobin, So audience feel that the hemoglobin is better than hematocrit. So why? Anyone who would like to take that up?
So hemoglobin is directly measured valuably. Hematocrit is basically when you are calculating it is MCV
RBC and MCV, we take that.
that.
So as rightly brought out, all your cool tests nowadays. So we are not measuring any more hematocrit by making the tube sediment on a side, taking what is a column at the bottom and all those things. So you take it nowadays, the Coulter, the way it gives you hematocrit is based on calculations. It's not measured actually. So in Coulter techniques, it's not good. But if you read Desi, if you read older textbooks, they say hematocrit is much better than hemoglobin. But that's once upon a time when it was used to be done manually, but not now. Okay, so please understand hematocrit is poorer than hemoglobin for defining anemia. So there are various ranges for hematocrit. So we have low values, high values. So one of you can take upon the caveats to the normal ranges that we have.
So sir, in children who are newborns, the hemoglobin normal values are usually higher. During pregnancies, normal range are considered lower, as well as when the patient or person grows older. In higher altitude, smoking patient or COPD patient, they are generally higher.
Excellent. So basically, when we say the normal ranges, they are not universal. Depending upon the setting, the normal range would differ. And also that brings us to the next point. So does that mean that we need to have different definitions for anemia for different settings? Yes or no? Okay, so you feel yes. So that means you mean to say South Indian, Thambi, or an Andhraite like me will have a different cutoff, and a North Indian will have a different cutoff, and a guy who is a Aryan race, pure Aryan race, Gora log, Gora Chitta log, they will have a different hemoglobin level. Then why is WHO giving one cutoff? Okay, so let's the expert answer on this. So is the definition of anemia different for different groups, and are there any Indian cutoffs?
So anemia, usually they give some range. So 12 to 15 you can consider, depend upon age also. And even if we run the same sample in a same machine, it also gives us some variability. So, and person age upon the older, younger, that also a variable thing. And if the hemoglobin is physiologically making that person stable around 12, 13, then the range can be considered than the single cutoff.
Perfect. So please understand, if you are doing a research in that particular situation, you take for a cohort, look at the baseline, draw a Gaussian curve, and say what's your median or the 95% of the confidence interval, and start interpreting people above and below that. But if you are practicing on a bedside, the WHO says across the world, you can use single cutoffs. So that's the difference of having a normal range and trying to pick up thing. And as rightly brought out, that brings the panelists exactly brought out difference with age groups. So in pediatrics, there is no doubt about it. For every age, the IAP has given clear-cut cutoffs, what hemoglobin to be taken as normal or abnormal for a given age. But the question appears, you also said elderly or younger patients. So let's take, there is a 77-year-old male with hemoglobin of 11.8 gram per deciliter. Is he anemic or is he not anemic? So how many of you feel he is anemic? Raise your hands. How many of you feel he is not anemic? Okay, Baki Nota group, Hindustan, Indian politics. Okay, so point is, okay, or they are sleeping. So your expert's opinion, please, on this. So for geriatrics, what do you feel?
Yeah, he is anemic, but we need to see what are his symptoms. Is he symptomatic for that hemoglobin?
Fine. So I agree totally with the doctor. So the point is, one, as far as the geriatrics is concerned, the cutoffs are same as normal adult population. Now we understand that in a geriatric population, more number of people have lower hemoglobins, but that does not mean we lower down our cutoffs. It just means please look for the additional causes, which could be multifactorial in this particular cases, and we need to evaluate them accordingly. And as rightly brought out, is he symptomatic or not? Symptomatic, please go ahead and evaluate them further. So that brings us to the case, this patient is symptomatic, how would you evaluate them? And do we evaluate them differently from the normal adults?
So this patient is having HB of 11.8. So we must found in the elderly population why the patient is having anemia. And the causes may be various, like 1/3 of the patient have nutritional anemia, 1/3 of the patient have either anemia of chronic disease or anemia of kidney disease, and 1/3 patient unexplained. So we must work up to find the cause of the anemia, because the cause may be benign, just nutritional, or the cause may be severe, like any leukemia or MDS sort of thing.
Bang on. So he has explained it totally. I don't need to go through the slides again. And as rightly brought out, the commonest causes after we have done the RFTs, iron stores, B12 and folate, that is nutritional and renal, are the first two common causes. And once you have ruled that out, the other next three causes are important. So MUGUS or monoclonal gammopathies, androgen deficiency. So the way females have menopause, in males there is a concept of andropause. So all endocrinologists would understand it better. MDS, if you are not finding anything, please evaluate for MDS or clonal cytopenias. Now, some experts say that if the patient is asymptomatic, you don't need to do anything, as was rightly brought out, which we agree to, and you don't need to perform a bone marrow. But if patient is symptomatic and unexplained anemia persists, please refer the patient to a hematologist for further evaluation. Now, this brings us to the next point. Whenever you look at anemia in any individual, what are the broad pathophysiological groups that you would like to evaluate them for?
So first of all, always, start from the simpler, definitely looking at CBC, I think, which you might come later, but then first is a nutritional, basically, whether there is an underlying nutrition, like old age, the commonest thing in India you will see is a poor dentition. They will say, okay, I'm eating like this for last 6-7 years, and then you will come to know, okay, what is their eating pattern. So nutritional deficiency should be first. First find out, means there can be simple tests like LDH, retic count. These are the simple tests which will tell you whether it's a hypoproliferative anemia or hyperproliferative anemia. Means whether some destruction is going on, vis-a-vis you are having something which is a production defect. And third thing is basically then comes to is a bone marrow, infiltration disorders, or maybe bone marrow, which is actually the factory sites where these cells are going to be produced. So if we differentiate, it should be nutritional, then a destruction, peripheral destruction, or maybe something like autoimmune disorders or anything like that, which can be, in fact, hyperproliferative anemia or can be destructive, either ways. And thirdly, any basically baking defect, basically.
Perfect. So, as a perfect analogy has been brought out, so consider there are no cars on this road on the Hitec City. So there could be multiple problems. We are not getting the raw material from China, or the Trump is clamping us. So raw material deficiency, micronutrients. Second, factories, Mahindra and Mahindra, which is very close by to Hyderabad. So that particular factory is not working. Why is it not working? Factory mein hartal chal raha hai, factory के अंदर machinery खराब हो गई है, the machinery has not been replaced. So factory problems or marrow problems. So that's what sir was saying about classifying it into proliferative or hyperproliferative. And lastly, सब कुछ ठीक चल रहा है, but फिर भी road पे नहीं है, तो सामने there is a police guy who is standing just near either on this side towards Habsiguda or that side towards Tanaga or onto that main expressway, clamping the people and blocking the people. So that is peripheral destruction. So this is how you classify any cytopenias. And if you go systematically looking at these three broad groups, you'll classify most of the anemias and also other cytopenias in that particular situations. So then this brings us to, once we understood what are the causes, how would you investigate these patients, or how would you go about evaluating these patients further?
So first, common things, nutritional things we should evaluate, like B12, folic acid, iron studies. On this, and if on iron studies you see iron deficiency, especially in postmenopausal lady or gentleman, then you should check for blood loss, in the sense stool, occult blood. And if it is positive, then go for colonoscopy and so on. So this completes the nutritional point. Then if nutritional wise, in the sense B12, folic acid, iron studies are normal, and there is anemia, which is suggestive of anemia of chronic disease, then look for what is the chronic disease which is instigating. Unless you correct that, it won't get corrected. Anemia won't get corrected.
Perfect, sir. So just putting that forward. So for the residents who are here, the same thing, I'll put it in a point-wise or a bullet-wise fashion. CBC, look at red cell indices, look at a peripheral blood smear, chemistry profile and reticulocytes, and based on the reticulocyte, classify the patients further. So whether they are having low MCV or high MCV, depending upon that, you can broadly classify that into group, and look at RDW. By looking at a combination of MCV and RDW, you can classify most of them. For those which you are still not able to classify, take retic count in addition to that, and based on that, you can again classify them into high retics and low retics, and you can put all your causes of anemia into this. Now, the most important reason why we are all sitting here, because Dr. Ganesh wants to know the answer for this. कि भाई उनका business कैसे बढ़ाना है? So, which all anemia cases should the patients refer to Ganesh? So that's the important question.
Case with pancytopenia should be referred to hematology.
Okay, only pancytopenia?
So the thing is that the baseline evaluation has been done and the cause is not apparent even after, it is not nutritional, nothing. As he has rightly pointed out, pancytopenia, sick patients, because they may not give you a time, because even leukemia and other things, if there are some abnormal cells reported, many of the times you will read the report may be reactive lymphocytes, or if you, especially I always tell, whenever you're looking at a pancytopenia, look at the neutrophil lymphocyte ratio. If the neutrophil lymphocyte ratio is well maintained, then that means the bone marrow failure is least likely, it will be more of a destruction. But if the neutrophil lymphocyte ratio is getting reversed, because many of the times you will see on the CBC, the blast will be reported more like a lymphocytes or monocytes. So always remember, if the neutrophil, always look at a neutrophil lymphocyte ratio. If that is something where you're looking at, definitely, and how sick is the patient. Because vitamin B12, despite of the pancytopenia, you will see stable walking inside your clinic. While those with leukemias, they will be quite sick by the time they did pancytopenia. I think these are the certain things if we look at.
Yeah, so very important, please. You should remember every point that sir has told you. So wherever there is an emergency, so there are few hematological emergencies which can come as anemia, pancytopenia, blast on the periphery, pancytopenia with hemolysis, thrombosis or bleeding, these three factors, and MAHA, which was shown by Tulika madam in the morning. So these are those patients where hematological emergencies, urgently send the patient to the hematologist. Diagnostic uncertainty. You tried whatever you wanted to do, jigri pugri, everything, and still the patient is persisting to have anemia, then please don't delay. Don't try shooting one micronutrient after another micronutrient after another micronutrient and refer the patient after 3 to 6 months to us, because actually some important diagnosis could have been missed by that particular point of time. Need for specialized evaluation or need for specialized treatment. So any of these groups are again those where a patient needs to be immediately sent to us. So these are the places where a hematologist opinion should be sought without any further delay. Now there are two bits of advice. No hematologist should feel कि यार anemia मेरा नहीं है, ये तो general physician को करना चाहिए. At the same time, no general physician should feel कि every anemia should go to a hematologist, because On today's date, whenever we talk in our country, among all the hematological disorders, the commonest in our country is anemia. And one national program which was started around 42 years back, Anemia Mukt Bharat, we have not been able to achieve it still. That is the biggest problem in our country on today's date. So anemia evaluation and management are important. Because of paucity of time, sir, I'll ask you only two important questions, particularly iron deficiency, because when sir described that we need to evaluate for iron. How should iron be prescribed orally? What should be the dosing of iron prescription when we give it oral iron? Ideal way of prescribing oral iron.
So, sir, any like it should, when some studies also came that around empty stomach, 12 o'clock, when hepcidin levels are less, then can be taken. And when this, also these studies recently came whether to give single day, daily, 2 times, 3 times or alternate day, the absorption on alternate day is much better when the receptors are less saturated. So most of these chemicals like ferrous fumarate, ferrous sulfate, all these absorptions of these are only 10%. But the best tolerable, which patient able to tolerate, is most important than the salt.
Absolutely. So two important aspects, please. Conventionally, all of us who have crossed 45, 50s, we have all been taught during our time, दिन में 3 बार iron खिलाते रहो. Most of the gynaes, most of the pediatricians, they all prescribe it that way. In pediatrics, they add zinc to it, which is a major problem. So giving it either once daily or on alternate days improves the absorption because of the hepcidin mechanism involved in it. The others have already been mentioned by the sir. I will not reiterate, very rightly brought out. The second important question, oral iron versus parenteral iron. Because even on today's date, for most of the people with gray hair or people with baldness, they are scared of giving parenteral iron.
Yeah. So first line of treatment for iron deficiency should be always oral. But if patient is not tolerating, then a patient should go for parenteral. However, there are certain conditions where you want to build up the hemoglobin at a quick pace, such as pregnancy, 2nd trimester or 3rd trimester, where and tolerability is an issue there. Then you should go for parenteral iron therapy.
So I will not repeat whatever sir said. Few more additions to that. These are the indications where you give parenteral versus oral. But one indication which is generally not written on the textbooks is most of our patients do not come back to us. Compliance is an issue. Logistics is an issue to come back to the hospital and everything. So wherever you feel that logistics is an issue and the compliance is an issue, parenteral is wonderful because the patient is in front of you. You are giving the iron, sending them off. You are at least assured that the iron has been repleted in these individuals. Number one. Number two, nowadays the formulations that we have, they hardly lead to any reactions. In fact, my dear friend Kundan is here. We have given tens and thousands of parenteral iron at RR. We have stopped giving oral iron there, and we hardly have seen any patient with any reaction in that particular thing. You once in a while you see those newspaper articles कि Bombay में किसी को कुछ हो गया, Delhi में सब किसी को कुछ हो गया, case चल रहा and all those things. But those are exceptions. It's rare to have a complication with parenteral iron if prescribed as per the drug insert. So they are extremely safe. So you can ensure the compliance to that particular therapy. Diphenhydramine earlier used to be given right, left and center. But in fact, that has been found now. By giving diphenhydramine, you lead to more problems. So you don't give diphenhydramine. And when you talk of different molecules, MCure will come and say, Mera ye acha hai. The people with isomaltose will come and say that they have done. Again, me and Kundan, we have people have done studies wherein we have compared FCM and the iron isomaltoside. And we also have done a study between 2 different companies of ferric carboxymaltose at RR. There is no difference between the companies. So efficacy remains more or less the same. Hypophosphatemia is something which might be slightly different in different compounds, and the speed at which you are giving and the number of divisions or the breakages that you are giving. Are you giving 500 mg once a week for 4 times? Are you trying to give 2 grams within 1 week? So that makes the difference for hypophosphatemia, but otherwise they are quite safe. Not that I am trying to propagate IV iron, but given the situations, particularly for tertiary care centers where your patients come from far off, this is one good option wherein you can take care of these things. And most importantly, look for a response, and the reticulocytosis is the best response, which should occur within 7 to 10 days to understand that whether the patient has responded to your oral iron or any form of iron replacement or not. If there is a lack of response, think of the following conditions which are happening, which needs to be actively evaluated and ruled out. So it's very important. It's just not iron deficiency anemia, or anemia does not mean iron de diya, kahani khatam ho gayi. You need to follow those patients up and see, have we really treated the cause of it or not? So the treating the cause is also equally important. So with this, we would like to stop it here, though we would want to discuss macrocytic anemia, B12 and others, but I think because of the paucity of the time, these were few points. Any other points which the panelists want to bring out, sir, please?
So the commonest mistake which we see in the clinics is prescribing calcium and iron together. So always ensure that patient is not taking iron along with the calcium, at least keep 3-4 hours gap. Tell them to have different timings for the calcium and iron. And by and large, if you are having anybody, especially male 60 years plus, then always keep malignancy on the card, because this is something which is common. If somebody is with the microcytic anemia as you are looking 60 plus, do not forget them once their iron is improved. And third and most important, just raising hemoglobin doesn't mean anything. You have to look at the stores, ferritin. So even so, a standard, depending on the severity of the anemia, the treatment can go up to 6 months. So just hemoglobin raised, hemoglobin is now 12, stop iron, no. So just ensure that they are also having adequate stores.
Any other points anyone want to bring out?
Similar thing, sir. So this anemia becomes vicious if the diet doesn't improve. So along with it, a proper dietary advice should be given. Otherwise, a vicious cycle will be there.
Is there anything that you want to add up?
Iron product should be, oral iron should be taken on empty stomach as far as possible, unless there is gastric irritation and gastritis, which is avoiding it.
We are frequently using IV iron, and we are not seeing any life-threatening side effects. So clinicians should feel safe while using newer preparations.
Absolutely. So that's where we stop. If there are any queries, we'd like to take it in the tea time. We'll not budge into the next program. But anemia is a huge topic. So what Gaurav spoke, what Tulika ma'am spoke in the morning, you need to put all of them together, assimilate them together, and digest them together. They are not bits and pieces, so you cannot take it in bits and pieces. So thank you. Thanks a lot. And thanks Dr. Ganesh and Yashoda Hospitals for giving us this opportunity. So thank you. I thank the panelists for active participation, please.
Thank you, Dr. Uday, for such an engaging discussion. I request all of you to be seated for felicitation program. Now I invite Dr. Ganesh Jaishetwar to take over.
chair 12. Good afternoon, everyone. It's indeed an honor and privilege to have such a hall full of eminent physicians, pediatricians, intensivists, as well as the national hematology experts on this august audience. So we are very proud to have Professor G. Narsimlu sir with us, who is the President-elect of Association of Physicians of India for this year. So we, on Deccan Hematolink 2.0, we take this opportunity to just have sir on the dais and little, just one. So before that, we will have just one 3-minute video to welcome Narsimlu sir from Deccan Hematolink. Sir. Just up, Betty.
Blood. It flows within us all. But do we truly understand its power? Let's dive into the lifeline of life itself.
every drop of blood carries the power to heal, protect, and sustain. In the battle against blood cancers, science is our greatest weapon. We at Yashoda Hospitals, Department of Hematology, always push the boundaries of hematology to go beyond what we ever imagined.
Deccan Hematolink 2.0 is honored to felicitate the President-elect prestigious Associations of Physicians of India, Professor G. Narasimulu sir, a visionary leader shaping the future of medicine in our country. True leaders don't create followers, they create more leaders. And I'm sure many of the eminent leaders from our Telugu region, spanning across all the specialties, are directly, indirectly Professor Narasimulu sir students in his illustrious career at the prestigious Nizam's Institute of Medical Sciences. Sir, your relentless dedication, innovation, and commitment to excellence continues to inspire generations of physicians across not just our region but the country. Join us as we celebrate this moment of recognition and gratitude for a leader who is redefining the landscape of healthcare. I now request Dr. M. Venkatramana sir to please begin the felicitation ceremony.
So good morning everyone. It's a very happy moment and very important moment for the Physician Association of India and Telangana especially. I request any senior physicians of these regions, please come on to the dais. Ramana Dandamurti Dr. Garu to come on to the stage. Please come on to the dais, sir. All the senior physicians, they can come on to the dais and participate in this important appreciation for our association. I thank Deccan Hematology link conducted by Dr. Ganesh Jaishetwar Garu in a big way, in a grand way. And we are very happy that Sir is appreciating API national body, and he wanted to facilitate Dr. Narasimulu Garu, who is the president-elect for this association this year. Few words about Dr. Narasimhan Garu sir. He did all his service at Nizam's Institute of Medical Sciences. He is a very hardcore learner, and as said by Ganesh sir, is a role model for so many PGs. And he did all this hard work to get rheumatology, MD and DNB into the NIMS institution. In the first of it's in the DM in the country, and with all this step-by-step movement into forward in the things, he has become previously Dean of the Association Physicians. Now he is the President of the Association. Give him a big applause. And I request the colleagues and the Deccan Hematology body to honor our Professor Dr. Narasimhan Garu, State President, National President. Come on, please. I request Dr. Professor Narasimhan Garu to address the gathering.
Hello, my friends. My friends, at the outset, I am very much thankful to the Ganesh and Yashoda management for inviting me and honoring me. Dr. Ganesh, I know since 2010 or 11, when I was brief period in Yashoda Somajuguda. He's a fine clinician and very ethical practice used to at the time. Now he shifted to here. And I don't know how to express my thanks. And I'm fortunate to be API National President. API started in the India 1943, then 47 Pakistan got separated. We have started growing, started with only 9 physicians, Guru Swami and Mitha. He was the Chief Minister of Gujarat. And API president was practicing also. And as for South is concerned, very less representation was there. Combined Telangana, Andhra Pradesh, I am the second president from this region in the API. After BKSI, I had this opportunity. It is a blessing of all of you, hard work, honesty. Don't think I'm a great man. I'm one among you. My schooling, a small village in a government school. Then most of the time in the government, and my service also in Nizam Medical Sciences. And I can say when I joined NIMS, most of the specialized services, people are going to Mumbai, Vellore or Madras, not available. When I joined, I was made in charge of acute medical care. When these things used to come, we discussed. And a great visionary, I can't forget Dr. Kakalapurao. Even though I was the lowest position, most of the professional things you should discuss with me. Sir, we should have more and more skill and specialty. For that, you need to develop specialties. Subject grown so well, one cannot concentrate. And 3 services are totally ignored by MCI. There is a rheumatology, hematology, medical oncology. We used to make a diagnosis, thalassemia, what next to blank. We used to make a leukemia, lymphoma, and very few people were there. So also, make rheumatoid arthritis put high dose of steroids within 2-3 months. Life is worse than a cancer patient. And then Subara told you, choose one field what you want. And then I started OP in 1990. And being a junior, I was shifted very frequently there and there. And it is the second highest OP in NIMS. And I was getting patients in rheumatology far from Mizoram, Agartala, everything, because no rheumatologists were there, only 5 or 6. Then it was so bad in the MCI, the MD rheumatology and DN, there is no DM rheumatology. Actually, it is DM rheumatology. How it started, I don't know. When I had to reschedule the things. And again, I can't forget one more name, very great misery, so silent worker. Dr. P.V. Narasimha came to address Nageshwara communist leader. It took 2 minutes. I want to tell something. His security people tried to stop me. Then he called me. What is the issue? I told about this. Then he didn't say anything. Within the next 3 weeks, a Directorate of Health, Union Health Minister, called me. They are getting invitation. Will be the syllabus committee member for rheumatology. Then how started? I prepared syllabus, and it's a commonly practice. All universities in India. Later, even Australia fellowship program also they took a copy for me. Australia, India have a common syllabus, verbatim, word by word. So we could contribute. Again, when I wanted department DM courses, there's so much opposition. For hematology opposition, rheumatology opposition, medical oncology, the Raghunath Rao made it there also now a big department. Oncology grown. And rheumatology started growing. Hematology budding should be started. My colleague, he wanted to be rheumatology, but he couldn't go behind a point. And then skill level developed in NIMS, and the people trained with us are in all corporate hospitals across not only Telangana, Andhra, across India. And I was happy the service is available. As for hematology, even when I joined in Yashoda, my friends, still very pediatric stage. Few people posing, but hardly anybody doing marrow transplant. Marrow transplant is required in rheumatology also sometimes. A refractory RA and a refractory cell, we go for a marrow transplant. And I told Ganesh, I think you should remember, only giving a blood transfusion and making a diagnosis, you have to go for complete Supreme Court treatment for patients, bone marrow transplant within the stage. Says, sir, I know I want to start it. I started, and I became big man. I think country is one of the largest series of bone marrow transplant done by the Ganesh. Kindly give big compliments to Ganesh. And apart from that, I'm very happy. My students in rheumatology are doing much better than me. Honestly speaking, even though I train them, at sometimes they are more knowledgeable than me. I'm very happy. So I love preference to between becoming Arjuna Dronacharya. I want to become Dronacharya. And one more thing, as API president, I want to say ideology API. Why you should become a member? It is a dissemination knowledge. If you treat a patient, you are benefiting that person and that family. If you teach, your students go and practice. You are indirectly helping more number of people. And next important point, research. Why should you do research? Anybody, why do research? It is vital if I don't get any extra money, extra salary. Only name will come. That to be, you have a technique of selling yourself. Otherwise, people like me get named very late. I tell one example. One Dr. Paul Emery, he didn't spend anything. 25 years of rheumatoid follow in NH. He has projected 0.25 milligram penicillin given for anybody. Erosion didn't prevent, but deformity was preventable. So this steroids were given for a symptom modification. Now we found that it has a disease modifying effect. And based on that, how this is low dose steroid acting on the cytokine blockade, then we have different targeted molecules. Today, large number of targeted molecules are there. When I took up, only 4 molecules are there: gold, penicillamine, and azathioprine, and levomethasone. None of the patients were improving. So now rheumatology hematology, medical oncology, very neglected, but growing very well, and we are serving better for the patient. Corporates are benefited, hospitals benefited, and people also benefited. I appeal all of you to become API member. These are the things I learned in API, Indian Rheumatology Association, and I put it into practice. It has given a fruits. I never thought in somebody's lifetime we get so many fruits and so many metamorphoses. In my lifetime, nearly more than 10 metamorphoses in the approach of rheumatology, hematology, medical oncology, and also cardiology, neurology. And I'm fortunate to have a directly associated John Hopkins Institute, Guy's Hospital, London, and many King George Hospital, Sydney. Still, I continue to be a faculty there. Now, online courses has helped us to go for these things easily. We're handling them. And all of you kindly involve in serving the patient in such a way that even poor patient, not affordable, within their affordability, serve them, that get more happiness. And also involve in teaching directly or indirectly, and go for research. API have a large number of funds. We give up to 1 crore rupees for research grant every year. If your project is good, the only condition is you should publish in JAPI and present our national conference. So learn the research techniques and ask Ganesh, whenever you do CMEs, put a small slot for workshop on how to do research, why to do research, how to publish paper, how to get grants. CSR, ICMR, DST grant 90% not utilized or wrongly utilized. There are no desert funds for research, but how to use it, we have to learn. Our syllabus not well addressed. That also MCA syllabus also going to revise. For medicine, I have revised. Now previously cardiology, neurology, abdomen, we don't call it abdomen, and respiratory, only long case, two long case. Now the exam pattern going to be changed. I don't know when the government is going to execute it. Common exam, like entry exam, exit exam also common, conducted by either MCI or DNP or different body. There is uniformity, in that way we're going to address it. And it may come within 1 year or maybe 5 years. Once that comes, it becomes, unless people who are not read well, it becomes tough. People read well, easily they pass. So a lot of uniformity may come. And one more last point I want to say, being the president-elect of API, I am the chairman of the scientific committee for Association of Physicians of India Conference, National Conference at Patna in the month of February 2026. I love to give opportunity to every one of you. It is my duty how to accommodate. Kindly write to me. You want to be a speaker, you want a chairperson, you want a panelist, you want a judge, whatever you want, because there is a body of 22,000. I am going to have 7 halls or 2 workshops. Anybody want to do workshop? Irrespective of wherever we are working, Yashoda, working Hyderabad and Nizamabad, irrespective of that. Any physician I want to love to respect, from Kashmir to Kanyakumari. Me being from Telangana or Andhra, I want to take care of every one of you. Kindly get motivated. Whatever you want to, you communicate to me a bit early, easy to accommodate. At last minute, because a lot of work there, scientific, preparing scientific, inviting people, arranging the logistics. Then once the material goes from me to the printer, I can't change it. So please get activated, be with us. I request Ganesh to coordinate also. And one more thing, last governing council meeting, I proposed a discounted membership drive. It is 40,000 life membership, now made it 10,000 till 31st April. So all of you go to website of API, download the membership and become member. If any issues, kindly communicate to me directly or indirectly through Ganesh. I see that you become member. And people who are API member, after more than 7 to 8 years, they're eligible to become an Indian College of Fellow of Indian College of Physicians. Along with the MD, you get FI, ACB, one more degree. And people who have done some work, at least marginal work, organizationally, academically, service-wise, it is my duty to see you get fellowship granted, because credential committee has to report to me next 2 years. So I can override the credential committee also. See that your membership, online you can do it. And I wish more and more people from Yashoda and also government, all medical college, not only Hyderabad, all district places, they become member of API and FICP, and also get the grants from PRF, Physician Research Fund. We'll give everybody. And not only from Hyderabad, I want to all the district players. I'm fortunate to mobilize Dr. Vaishan Raju, Nageshwar Rao, Naval Chandra, Uday Lal, and these become Governing Council members, and Rakesh Sai. Recently, there was a saying people, all Hyderabad people are getting opportunity in district place. It did motivate me. Now, Dr. Pawan from Varangal, I also motivated him, made him work. I didn't just push them into become a Governing Council member because very tough. So he has successfully become Governing Council member. I wish all the people sitting in the dais, all the audience, maximum will become Governing Council member, and so not only in Hyderabad, at national level, at international level. And I wish this event highly successful. I wish Yashoda also all the success, and only appeal to Yashoda management, treat both rich and middle class poor patients within their affordability. What is the ideology N.T. Ramo started Nizam Medical Sciences, and I don't know what all I speak. I don't want to take much of your time of hematology. I ask my concluding them, long live API, long live medical ethical practice, long live non-commercial medical practice. This is the prayer I am doing it. And last, there is a violence of the doctor, we need to address it, that we may take a forum. And I thank you once again. Thank you all.
Thank you, sir. Dr. Sthita Pradnya, please come. Sir.
Thank you very much, sir. Thank you very much, sir, Dr. Ganesh Garu, for felicitating and appreciating the body and the coming president of the API national body. Thank you very much, sir. The program was very successful, very meticulously conducted, and very useful for all the practicing physicians throughout the country. Thank you very much, sir. Dr. Ravi Kumar Garu is the Ravi Prasad is in the Dr. Shankar from Jagatyal. Dr. Shivarama Krishna. Dr. Shivarama Krishna from Kamam. He organized state conference. Sir, the doctors from Kurnool are also there on the hall. Please, I invite them onto the dais. Ravi Kaladhar Reddy, Dr. Maheshwar Reddy, Dr. Ganesh, young dynamic physician from Manchiral. He is also a student from NIMS. Ganesh tarvata evaruన్నారు? Dr. Chandrasekhar Garu from Adoni. Naveen Kamareddy, please come on to the dais. Srinivas Reddy, Mahabub Nagar, Jagatyal. Dr. Rajeshwar Rao from Mudol. Vijay Babu. Come on, from Manchiral. Vijay. Dr. Vijay Babu from Manchiral. దాని పక్కకు ఉన్న వాళ్ళు ఎవరు? ఏమైనా ఐడియా ఉందా? Sharan Vajappa from Gulbarga. Shashikant, Dr. Shashikant. Nagavardhan Reddy garu. Dr. Chetan Chauhan. Karnool atanu. Dr. Mahesh Reddy from Karnool. Ravi Kaladhar Reddy. Dr. Ravi Kaladhar Reddy from Karnool. Shashikant Reddy. Shashikant Reddy, please on to the dais. Nagavardhan Rao. Nagavendra Rao. Nagavendra Rao. Naveen. Naveen from Kamareddy. Shashidhar Reddy. Shashikant Reddy. Dr. Nagavardhan Rao from Hyderabad.
Dr. Venkatramana is also from NAMES and practice at Nizamabad.
Thank you so much. I now request Dr. Shweta to continue with the conference proceedings. Thank you so much, all of you. for your time and patience. Thank you.
Ladies and gentlemen, welcome aboard Deccan Hematolink 2.0. This is your captain, Dr. Ganesh Jaishetwar, along with my co-pilot, Dr. Stitha Pragna. Thrilled to have you on this exhilarating journey through the skies of practical hematology, groundbreaking innovations, and cutting-edge research. We are cruising at an altitude of great expertise, accompanied by 200-plus national and 10-plus international faculty experts, ensuring an insightful and inspiring flight. Destination: the latest in hematology, hemato-oncology, and stem cell transplants. Case-based discussions, essential updates, and breakthrough therapies. Participate in quizzes and grab 10-plus smart rings and many more prizes. Connect with top minds in the field and expand your professional horizons. In-flight services, pharma and innovation hub, and exhibition zones. There is Wi-Fi on board. Stay connected and share your experiences live. Your safety is our priority. In case of an emergency, please use the oxygen masks and dial 105910 for immediate assistance. Rest assured, we hope it won't come to that. We are set for an exhilarating 36-hour journey at an amazing height of the 5th floor, where you'll explore the latest innovations, trends, and breakthroughs in hematology. Feeling hungry? Step outside the premises during breaks to enjoy some refreshing tea and Karachi biscuits, as well as the Deccani special dum biryani. As we cruise through this journey, take a moment to appreciate the Deccan region, a hub of pharma innovation, IT revolution, and rich cultural heritage. When you're not immersed in hematology, explore the city's iconic landmarks like Charminar, Golconda Fort, Buddha statue, and Falaknuma Palace. Don't forget to visit the bustling markets for pearls and bangles, a hallmark of this vibrant region. A quick reminder, exit will be only on the right side, so please plan your movements accordingly. I kindly request all participants to follow the instructions of our crew and move only during scheduled breaks. Your safety and comfort are our top priorities. Once again, on behalf of Deccan Hematolink 2.0, I thank you for joining us on this journey of knowledge and discovery. Sit back, engage, and let's revolutionize hematology together.
Let's start session 6. I would like to invite chairpersons for this session, Dr. G. Narsimulu, Rheumatologist, GVN Medical Center, Hyderabad, Dr. Sharana Basappa, MR Medical College, Gulbarga, Dr. Trilok, General Physician, Hyderabad. And the speaker for this session, I would like to invite Dr. Vivek Radhakrishnan, Hemato-Oncologist, University Hospital of Southampton, England. Over to you, sir. Thank you. I would like to invite Dr. Vijay Misale, sir, as a chairperson, senior cardiologist, Nanded. Over to you, sir.
Good afternoon, everyone. I hope your seat belts are on, and I hope my talk is all right so that you don't squirm in your seats and run away after that. Thank you, Ganesh, for inviting me to this conference, and Yashoda Hospital for the brilliant setup and organization of this conference. Today's topic that Dr. Ganesh advised me to speak was on Hodgkin lymphoma in 2025 and can we improve cure. He did mention that the audience consists of many of you physicians and a mixed crowd of oncologists, pathologists, and from different specialties. So I've tried to make it as much less data as possible and try and keep it as simple. So these are my disclosures. So the outline of my talk is essentially to see what is the current status of Hodgkin lymphoma outcomes in the world today, and what is new in terms of immunotherapeutic targeting, and what are the different case scenarios in which we are making a difference in the treatment of Hodgkin lymphoma. Now, the unique thing of Hodgkin lymphoma is that it is one of the most curable cancers. And what has happened over the last 4 or 5 decades, and if you just take the example of one country where we have enough data, is in England, nearly 75% people are living more than 75% people are living despite a diagnosis of Hodgkin lymphoma and having received treatment, which means that this was not the case 5 decades back, and chemotherapy and the combination of radiotherapy has brought it forward in a way that we never thought was possible. And as our results are improving, more than 90% of patients today with Hodgkin lymphoma are cured. More than 95% in early stages are cured, and in advanced stages we are breaching the level of 90%. And more than 80% of patients are living longer. And this was all possible just with chemotherapy and radiotherapy. But are we all happy that we have achieved cure, and what happens to the remaining 10%? Now, what happens despite these cures is that if you compare a cohort of patients who have received Hodgkin lymphoma treatment and a group of patients who have never been diagnosed with Hodgkin lymphoma in their life, the mortality rates among patients who have received treatment is higher than those who have never been diagnosed with Hodgkin lymphoma. So essentially, it means that mortality, if you compare it with general population, patients who are living post-treatment with Hodgkin lymphoma remains high. Now, that is primarily because of a direct effect of the treatments that these patients have received either as chemotherapy or radiotherapy. So if we have to improve outcomes in Hodgkin lymphoma, not only do we have to improve the response rates with newer treatments, we should also reduce the toxicity of the treatments that they have received, or what was the standard of care with chemotherapy and radiotherapy. Now, conventional treatments are like using a nuclear bomb for something that can be treated with just a bullet. So there is a tangible shift to the understanding of the biology of the disease and treating Hodgkin lymphoma with more targeted therapies today than using chemotherapy and radiotherapy. And immunotherapy has become that new sentinel of use in Hodgkin lymphoma treatment. Now, if you reimagine the biology of the Hodgkin lymphoma from a standard H&E slide that we see on the left of your screen, where you see the classic Reed-Sternberg cell as marked on the slide, we have now more information on the tumor microenvironment of Hodgkin lymphoma, and with the gene profiling, we can classify Hodgkin lymphoma into 3 broad groups. And that is where I think that is the next level of taking the pathology and microenvironment of Hodgkin lymphoma. If the 3 broad groups are the tumor group 1 are those which are oncogene-driven Hodgkin lymphoma. The second group is the inflammatory immune escape type of Hodgkin lymphoma. And the third is the virally driven Hodgkin lymphoma. Now, as we go ahead, these have got implications on the response to different treatments and how they have on long-term prognosis with Hodgkin lymphoma. And based on this understanding of immunology and the microenvironment of Hodgkin lymphoma, we now have broader targets for Hodgkin lymphoma treatments. Some of them are primarily immune targeting agents like brentuximab vedotin, which actually targets a surface receptor which is common in Hodgkin lymphoma, which is CD30, and the other two are checkpoint inhibitors, which circumvent the immune blockade that is imposed by Hodgkin lymphoma cells on the surrounding immune microenvironment of the body. So the immune checkpoint inhibitors which have been approved are nivolumab and pembrolizumab. And if you look at the screen, there is a multitude or a panoply of drugs that are being tested in Hodgkin lymphoma today in advancing cures that may be possible for nearly 100% of patients, taking it beyond 90%. Just to give you an overview of how these drugs work, one of the drugs that most of the oncologists, including Dr. Ganesh uses in Yashoda Hospitals, brentuximab vedotin, which is an antibody drug conjugate. So you may be familiar with monoclonal antibodies, especially rituximab. Similarly, you have brentuximab vedotin, which is a monoclonal antibody. It is like a drone with a payload of a bomb. So you have a toxin that is carried by this antibody, which is directed against anti-CD30. It enters the cell using the CD30 receptor and kills the cell. So it's an antibody drug conjugate. The other group of drugs which commonly are practiced by most hemato-oncologists as immune checkpoint inhibitors, this is a group of drug which actually abrogates an immune blockade that is caused by the tumor cell. So the tumor cell produces a ligand called as PDL, which binds with a ligand with a receptor on the tumor, on the T cell called as PD1, and it makes the T cell not recognize the cancer cell as cancer cell. It recognizes the cancer cell as normal cell. Now, if we block this using an antibody like nivolumab and pembrolizumab, the T cell starts recognizing the cancer cell as cancer cell and starts killing them. So that's the principle of using immune checkpoint inhibitors. Now, with the advent of this, are we getting closer to a cure in Hodgkin lymphoma? So we ask ourselves 5 broad questions. Are there better tools for investigating Hodgkin lymphoma today? Can we find new, less toxic standard for advanced stage lymphoma? Can the new agents of treatment avoid radiotherapy in patients with early stage disease? And can we improve results in older individuals? And do we have newer strategies for recurrent disease? So I take you through a first case scenario. We have a 22-year-old patient who presents, he's an army man, comes with easy fatigability, on-off fever episodes, night sweats of 3 to 4 days, and central chest discomforts, some weight loss, reports to the GP, and has some involuntary weight loss, not significant, but has lost 3 kgs nevertheless. He was extensively investigated by his GP and by the infectious disease team. If you look, it is more or less unremarkable investigations, except that he had a raised ESR of 54, extensive evaluation with a full infectious disease profile, including multiple blood cultures, blood-borne virus screen, TB, everything is negative. EBV and CMV were checked, they were negative. Autoantibody panels were sent, ACE was sent, all were negative. And an initial chest X-ray was unremarkable. Multiple courses of antibiotics. This is a typical case scenario that most of you would experience, and we'll all be scratching our heads as to what is happening. Even a bone marrow aspirate biopsy was done, which did not show. Fortunately, not treated with steroids. Now, a repeat chest X-ray by the GP revealed a small right hilar shadow, and then the patient was referred through the infectious disease team to us with a PET CT scan. Now, a PET CT scan showed this, and if you see, there is, sorry for the poor quality of the image, but it essentially showed a hilar mass. Now, looking at the location, it is difficult to do a CT-guided biopsy. So the pulmonologists went in and did an EBUS guided biopsy, that is an endoscopic bronchial ultrasound guided biopsy. Twice, on both occasions, it came back as reactive lymphoid infiltrate, no evidence of malignancy. AFB was negative and EBUR FISH was also negative. And we finally had to knock the doors of the thoracic surgeon who did a mediastinoscopy biopsy and came back with classical Hodgkin lymphoma, and a repeat bone marrow biopsy showed that this was suspicious for involvement. So here you have a young adult, 22-year-old, with a stage 4 Hodgkin lymphoma. And if you, of the series of investigations he underwent, it took nearly 4 months for us to come to this diagnosis of Hodgkin lymphoma. Now, the first question we ask is, are there better tools? So there is now a marker called as serum TARC. Now, this is not new. It has been in proceedings for the past 2 to 3 decades. There is some data to say that serum TARC is elevated and it precedes the diagnosis of Hodgkin lymphoma by several years. So what is TARC? It is a thymus and activation related chemokine. It can be done by a simple serum ELISA test, and it is secreted by, the unique thing about TARC, it is secreted by the Reed-Sternberg cells, not by normal B cells. It is present in more than 90% of Hodgkin lymphoma patients, and it is negative in non-Hodgkin lymphoma. So that can be a discerning factor. And the only differential to this serum TARC is it is exaggerated in self-limiting immune responses. So that's the differential, but it's highly sensitive and specific. So the implications is, in this patient, if we had done a serum TARC much earlier, we would have probably picked up the diagnosis or at least a suspicion of that. So there is a potential use for serum TARC, and you'll hear of this more in the treatment of Hodgkin lymphoma, especially in the diagnostic setting where we are evaluating unexplained lymphadenopathy. We have, as a potential response or MRD marker, or for monitoring patients in follow-up, or as a screening tool. But you know, for such a small incidence of Hodgkin lymphoma, it is not a test that we can use it as a screening tool. The next is there something better in imaging? So today there is the possibility of a new imaging tool called total body PET, which is a high resolution whole body imaging, which is essentially different from a regular PET CT scan in that in a regular PET CT scan, one donut moves up and down to screen section by section, whereas in a total body scan, you have a full loop in which the patient goes in and you image everything simultaneously. So what are the benefits? The benefits is it is quick, ultra-fast imaging. There is no lag. You can vary the dose, especially in children, you can expose them to lesser dose of radiation, and you can also get delayed imaging in these patients. So if you look at the evaluation of Hodgkin lymphoma, the standard evaluation is to use a PET CT, bone marrow aspirate biopsy in some situations, and you then stage and risk assess the patient. And then you risk stratify the patient into favorable and unfavorable groups. But generally, stage 4 is an advanced disease, and you have to treat it with intensive treatments. And if you look at what is standard treatment now, you can either go with a PET-guided approach or a PET-independent approach. The standard of treatment earlier was to use, if you're going by a PET-independent approach, was to use escalated Birkhoff times 6, or if you go by a PET-guided approach, you either go with the Rathel approach on the right side, where you give 2 cycles of ABVD, look at the PET report, and then decide whether the patient continues with ABVD or you escalate with escalated Birkhoff, or you go with the HD18 study, which determine the number of cycles of escalated Birkhoff, which is an intensive chemotherapy combination regimen. But the advent of immunotherapy has given us the opportunity of exploring antibody drug conjugates like brentuximab vedotin in the upfront treatment of Hodgkin lymphoma. So in this setting, you have patients with diagnosis of advanced Hodgkin lymphoma receiving a combination of brentuximab with AVD by removing bleomycin, which is associated with significant lung toxicities. So this was not essentially a PET-guided treatment approach, but only to take off those patients who had progression of disease. The remaining patients, all of them received 6 cycles of AAVD, and completed treatment and outcome assessment was made. Recently, the 6-year outcomes of this study from the Echelon-1 trial was published, which showed that there was a progression-free survival benefit of close to 7% in patients who received AAVD, and that also translated into an overall survival benefit of close to 4%, 4 to 5% in those patients who received AAVD. Now, there was a strong benefit in patients who had high risk factors and a higher stage in stage grouping at diagnosis. Similarly, a new study which used nivolumab, a checkpoint-based inhibitor, along with AVD in newly diagnosed Hodgkin lymphoma. This was also a PET-independent approach. All patients got either 6 cycles of nivolumab AVD or 6 cycles of brentuximab AVD, and an end-of-treatment response assessment was made with the primary endpoint being progression-free survival. Last ASH, we had the publication of 2-year progression-free survival reports, and the difference between the two was that nivolumab AVD actually improved progression-free survival by nearly 9% in patients who received this treatment versus those who received brentuximab vedotin plus AVD. The other study was from the German Hodgkin study group, which tested the combination. They replaced escalated Biacop with a combination called Brecard by using brentuximab along with etoposide and the rest of the drugs, replacing procarbazine with dacarbazine and prednisolone with dexamethasone. So it is far better tolerated, it is less intensive, and they used a PET-based approach. And if you look at the graphs on the right side, the improvement in progression-free survival was 4%, which is unheard of in patients with advanced stage Hodgkin lymphoma. That means we have the potential of curing close to 95% of Hodgkin lymphoma patients with far less morbidity than with escalated Biacop. So 42 versus 59%. So finally, you have the guidelines from the NCCN network, which now has included not only NAVD, that is nivolumab AVD, along with the brentuximab vedotin-based regimen. They have also included a suggested algorithm where patients start with ABVD times 2, and if they have persistent disease after 2 cycles, you can consider them to go ahead with a Brecard-like regimen to intensify treatment. So this is an escalation treatment. So if I try to make conclusions from advanced disease, what the message for Hodgkin lymphoma now is newer antibody-based treatments are likely to replace chemotherapy alone regimen. So it's going to be increasingly chemo-light. And initial therapy with nivolumab seems to be on the up end because it is better tolerated, results in a higher progression-free survival, and a potential increment in overall survival if you compare it with ABVD. And if you look at de-escalation efforts, there is a good possibility that we may be able to de-escalate treatments in Hodgkin lymphoma from highly complex and toxic treatments like escalated Biacop and de-escalate it to simpler treatments like NAVD and brentuximab and AVD. Do we have time? Thank you. So at the end of it, I would like to conclude by saying that we are at that inflection point where immunotherapy, particularly checkpoint-based inhibitor, is changing the way we think about Hodgkin lymphoma treatment. More effective initial therapy for early stage disease avoids radiotherapy or reduces the chance of radiotherapy. In fact, if you look at the NAVD trial, of all the patients who received this treatment, just about 4 patients received radiotherapy in the advanced setting. It allows de-intensification treatment, and in advanced disease, NAVD seems to be better tolerated in older patients. And for newer approaches, you have a whole plethora of new drugs, including anti-CD30 CAR T cells, which are making headway into Hodgkin lymphoma treatments. I'm sorry I could not cover all the aspects, but I'm conscious of the time limits of this conference. Thank you.
Thank you, sir. I request all the speakers, chairpersons, and panelists to collect mementos at the podium near photo booth. For our next session, I would like to invite Dr. Samir Melinkari, Clinical Hematologist, Dinanath Mangeshkar Hospital, Pune. Thank you.
Good afternoon, and thank you, Ganesh and team, for inviting me here. I'm amazed by the amount of energy you possess. You know, I'm entering from this area, it's like entering through a blood vessel, don't you think? Anyways, so thank you. There was slight confusion in this lecture. I thought Zydus was supposed to sponsor this lecture and asking me to speak on letter mover, but we have stuck to the original topic of how I treat infections in immunocompromised patients, and I'll try to amalgamate the two and finish, or give you whatever GAN I can give you in the next 20 minutes. Okay? Yes. Okay, so the topic is how I treat infections in immunocompromised patients. So why do patients with hemato-oncology develop more infections? Because they receive chemotherapy, because blood cancers, white blood cells are inherently compromised, because after bone marrow transplantation, the donor cells that come in, they take a long time to actually become normal, and because even most targeted therapies can cause in immunocompromised states, because the targets on the tumor cells are also present on some normal cells. So whether you're using chemotherapy, basic chemotherapy, whether you're using more advanced chemotherapy, you're going to have neutropenia. If you're using a bone marrow, transporting a bomb inside the bone marrow, destroying everything that you have, you will have even more neutropenia. But even if you're trying to target with monoclonal antibodies, you think you're going to target only one spot and destroy the whole demon. But nevertheless, despite your targeted therapies, monoclonal antibodies or small molecules, you will still cause a certain amount of immunosuppression in most patients. So what are the types of immune defects that you can have? So if you have severe neutropenia, the more common infections that you're going to have are bacterial infections and fungal infections, right? If you're going to have more humoral dysfunction, that is, you have B and T lymphocytes are getting suppressed, then you're going to have predominantly more viral infections, but also you can have pneumocystis carinii, you can have encapsulated bacteria, and in late stages, mycosis as well. So the severity of neutropenia is the highest in these conditions: ALL, AML, aplastic anemia, MDS, and allogenic bone marrow transplantation. When it comes to multiple myeloma, you have profound hypogammaglobulinemia, and therefore initially you have a high risk of bacterial and viral infections in the first 3 months, and vaccination is important. Lymphomas, because of the severe hypogammaglobulinemia, again, you're going to have encapsulated organisms, bacterial infections, and viral infections that can infect the patient. Okay, so now let's come to a case scenario where you have a patient with the AML who undergoes intensive chemotherapy, and post-chemotherapy, the WBC count drops to 100. He develops the first episode of fever about 101 degrees, and other vitals are normal. So my question to you is, what will you assume this is? What is the most probable type of infection? That's viral, bacterial, or fungal. And when you draw a blood culture, how much of blood do you draw? And how many bottles? Anybody? All right, so remember that fungal infections require a sufficient duration of neutropenia. Okay, you can't have neutropenia developing in 2-3 days time and suddenly you got a fungal infection. That's a little rare. So you must assume that the first fever in a patient with who has recently developed neutropenia must be assumed to be bacterial unless proven otherwise. This is not a central a setting for a viral infection, except herpes infection, which can develop in immunosuppressed in neutropenic patients. And in India, in general, we have a huge preponderance of gram-negative organisms as compared to gram-positive as compared to the West. And therefore, most of the times, we have to focus on antibiotics which are going to target gram-negative infections. So how do you react to the first fever spike? We draw a blood culture which has 40 cc of blood. That's the ideal, right? 40 cc of blood, 20 from the peripheral blood, and 20 cc from the PICC line. We argued with a microbiologist saying 40 cc is too much, but they said nothing doing, it has to be 40 cc. We do not send a procalcitonin or any other biomarker for the first fever, okay, because it takes time for these biomarkers to become positive. In the first fever, most of the times it will be negative. And we give antibiotics that would cover GPC and GNB. The choice varies between hospitals depending upon the trend of the bacteria that you have in your hospital. In the Nath Mangeshkar Hospital, we either start with peptides, but now we've moved on to ceftazidime and enmetazobactam as the first line, or meropenem, depending upon what we feel the clinical scenario is. Now, this is just like an example of a particular institute where they documented the kind of isolates that they had, right? Predominantly gram-negatives and also less commonly gram-positive isolates. And then you have your Enterobacteriaceae being the most common. Now, supposing your blood culture flags positive. The bacteria said it's positive, okay? What is the next step? What is the next step? What would you do next? So in our institution, this is the ideal scenario, right? We have a machine called as the MALDI-TOF, right? MALDI-TOF is basically a mass spectrometry-based machine. Costs about 1 crore, but very little, what shall I say? There's no reagents required for this. So the moment your culture flags positive, you have to insert it inside the MALDI-TOF. And within 10 minutes, it will tell you what the bacteria is, right? So here you can see sepsityper. It has shown Klebsiella. Okay. Now it'll only tell you what bacteria it is. It won't tell you the sensitivity pattern. It won't tell you the resistance enzyme that is expressing, but it gives you an idea. Now in your hospital, you must have a surveillance every year of whatever isolates you've got, right? So this is in our culture data in 2023. Now this is for our commonest bacteria, E. coli, Klebsiella, and Pseudomonas. Now we have our data of which antibiotic these are most sensitive to. So for example, if you see E. coli, most sensitive to fosfomycin, but also to carbapenems. Klebsiella, most sensitive to ceftazidime avibactam. Pseudomonas, something else. So you should know because these keep changing. You can't have a Klebsiella being sensitive to the same bacteria for the next 10 years. It will keep changing, right? So you must have a constant vigilance about this. So this is our data for gram-positive negatives and gram-positive. Now how this is going to help me? If it turns out to be Klebsiella in a patient who's got 100 WBC count and high fever, I'm going to add on ceftazidime avibactam as my first choice of antibiotic, and then decide to de-escalate later on. That's how we generally function. Now, what's the next step? Okay, so next step is that in the next 6 hours, what we get is we look at the enzymes that the bacteria is producing. For that, you need to identify the resistance genes in the bacteria that is likely to secrete a particular enzyme. So here, what we do is we have this. So it's a multiplex PCR from a company called Master Diagnostica, but there are others as well. And this will tell you by multiplex PCR and macro reverse hybridization that this is Klebsiella pneumonia, and it tells you what enzymes it is expressing. So here it's negative for ESBL, CTXM. It's not expressing any marker. So we know this is a sensitive Klebsiella. We can immediately de-escalate our antibiotics, right? And sure enough, in the next 2 days, we get to know that this is a very sensitive bacteria. So we have already downgraded to something like ceftriaxone or cefepime. But on the other hand, if that showed you that the same Klebsiella was expressing SHV, CTXM, NDM, OXA48, then I know that this is a really resistant bug, and I have to give a combination of ceftazidime avibactam with astronam. So that here your infectious disease team is involved, and they and you together have to decide what are the best antibiotics for that patient. So in a neutropenic patient, you can't wait for the final sensitivity to come, right? That may take 2 or 3 days. You need to act within hours. So we've got a MALDI-TOF, tells you what bacteria it is. We've got your resistance enzymes, tells you in the 6 hours what your antibiotic choice should be. And that's how we treat them. Now, supposing, how do you react to subsequent fever spikes? Supposing the culture was negative or it was positive, but later on, 4 days later, again there's fever. Fever is not gone away. In that case, we repeat blood cultures again. We send biomarkers this time. We look at the procal. If the procal is constantly negative, can't just randomly add antibiotics. You've got to focus on other things. Image, look at the chest. That's a very common size of infection. Look at the gut, look at the urine, and see where your focuses of infection is. And then empirically change to second-line antibacterials. Right? So here your ID team again is involved. But in general, these are the most common bacteria: E. coli, Klebsiella, Pseudomonas, and Acinetobacter. Okay. Now another case, this is an 18-year-old male who develops febrile neutropenia on chemotherapy, started on piptaz, but then 2 days later, he starts developing these kind of skin lesions. And you look at the CT chest, there's a nodule over here, right? So when there's a nodule over here and a lesion on the skin, commonest thing that you're going to pick up is a fungus, more commonly, but of course you can have bacteria as well. So what the first thing to do is you take a biopsy. If your blood culture shows positive, well and good. If it doesn't, take a biopsy from that lesion and immediately work up on that. So here, the blood culture showed this growth over here. You put this under the MALDI-TOF and it tells you this is Fusarium, completely new bug. And if you're going to sit with just your regular antibiotics with this kind of a bug, the patient is going to die, right? So this is the importance of having rapid diagnosis. Commonest fungal infections in hematology are Candida, Mucor, and Aspergillus. And how you suspect, rarely you can have others as well. More common with more severe neutropenia. And how do you suspect fungal infections? New appearance of skin papules or nodules in a febrile patient, more commonly Candida. New onset pleural rub in a neutropenic patient, auscultate the chest. This typically indicates an angioinvasive fungus such as Aspergillus or Mucor. Fever, if the fever is not resolving despite 72 hours of good gram-positive and gram-negative cover, you're more likely to have a fungal infection. So start searching for these. Coming to the post-transplant scenario, how much time do I have? 5 minutes. Coming to the post-transplant scenario, so in the pre-engraftment period, when you're doing you've given your conditioning, you have severe neutropenia, you've got all these kind of infections that we just discussed. Post-engraftment, neutrophils have come up, but the lymphocytes have not recovered. For the next 3, 4 months, 6 months, the lymphocytes have not recovered, and therefore you're going to have all kinds of viral infections and other, rarely you can have Aspergillus and other fungal infections as well. So since I have only 5 minutes, I'm going to discuss a little bit of CMV infections. I'm just not going to discuss this in too much detail, but I'm going to give you tips on how you manage, and maybe you can tell me how you manage this infection. So the risk of CMV infection in post-transplant particularly is based on seropositivity. Maximum risk is if the donor is seronegative and the recipient is seropositive. If both are seronegative, it's the least risk of catching a CMV infection. And moderate risk if the recipient is seronegative, donor is seropositive, or if both are seropositive. That's a moderate risk. How do you treat CMV infection when you develop one? The first thing is we start monitoring it prospectively. As soon as the patient engrafts, you start checking weekly CMV PCRs at least. The first line therapy will always be ganciclovir or valganciclovir, and even foscarnet is approved for it. Oral valganciclovir is non-inferior to IV ganciclovir in non-life-threatening infections. So if you have a serious severe CMV infection or especially CMV disease infecting an organs, don't use valganciclovir, use only ganciclovir. Now, patient should receive, how long do you treat with ganciclovir, right? You give it until 2 consecutive weekly PCR reports of CMV are negative. Supposing you give it for 2 weeks, after 2 weeks, the first report of CMV comes negative, give 1 more week, the second one is negative, stop treatment. Or if you feel that the immunosuppression is still very intense, a patient is already on 2-3 immunosuppressants for GVHD, then you may decide to give maintenance doses for a longer period. The biggest problem with ganciclovir is hematological suppression, but it's important to continue treatment as long as there's no severe neutropenia. Give GCSF along with it and try to manage. If you feel that this neutropenia is very severe, then you may decide to switch to something else, right? Now, foscarnet is a good drug for CMV, for resistant CMV infection. We typically use it only for resistant cases. Won't discuss this too much. Cidofovir, remember, cidofovir is not better than ganciclovir for treatment of CMV. It is in fact a little inferior. But we use it if this neutropenia is very severe, right? And then you can't use this, then you can use cidofovir. Cidofovir, biggest problem is nephrotoxicity. If there's nephrotoxicity, you can't use cidofovir, okay? So you switch empirically only in the setting of very severe neutropenia or some toxicity because of which you can't give ganciclovir. Okay, I don't have time for this, just only 2 minutes, but quickly. This is a girl who underwent transplantation for thalassemia, and post-transplant, she developed this, a few months later, she developed this bad infection, came with respiratory failure, and the endotracheal secretions showed more than 3 lakh copies of CMV. We started ganciclovir. To cut a long story short, ganciclovir wasn't working all that well. We gave it, but it kept on worsening. We gave her foscarnet. She developed severe myopathy. We had to stop the foscarnet because of that. Gradually, it worsened again. And then CMV-specific immunoglobulin can be used, but very expensive, not easily available. CMV-specific cytotoxic T cells, a crying need of the hour, but we don't have it available in India. To import it is very difficult. And in this case, we was the first girl in India who received letermovir. Okay, it's not used for treatment actually, but in this case, letermovir worked in her, and for a year she was on letermovir, and finally the disease went away only with letermovir. But that's not the treatment. What is letermovir? She was in PSU for almost 1 year on a ventilator, and finally she's absolutely well at the moment. So what the focus of the last few minutes is letermovir. Letermovir is a CMV terminase complex inhibitor indicated for prophylaxis of CMV infection in adults and pediatric patients, and also those who are undergoing kidney transplants. So the NEJM paper which showed the benefit of letermovir, patients who underwent bone marrow transplantation were randomized to receive letermovir versus placebo as prophylaxis starting from engraftment up to the first 24 weeks. And this clearly showed that the letermovir group showed a significantly lesser CMV reactivation. You can see over here, significantly lesser CMV reactivation in both the high-risk group as well as the low-risk groups. And this established the role of letermovir prophylaxis in all patients undergoing allogenic bone marrow transplantation. And also CMV, although it may not directly cause mortality, it's a very important contributor to all-cause mortality, right? So when you have CMV infection, all-cause mortality is increased, and that too is significantly reduced by addition of letermovir in all the scenarios. Very, very safe drugs is the best part of it. All the other drugs for CMV have some catch to it. They have some toxicity, but letermovir has very, very little toxicity. No myelosuppression, no nephrotoxicity. That's the dose of letermovir. In an adult, you typically use 400 milligram, 480 milligram once a day, or 240 milligram along with cyclosporin if you're going to use, because it doubles the dose of that. And those are the milligram per kg doses for pediatric patients. In general, you must monitor for CMV weekly, and for adeno and EBV, at least we do it once in 2 weeks post-transplantation, at least until 100 days or more. And finally, this is my last slide. This is my last slide. So what is this? This is a WhatsApp group chat, right? What is this? This is between hematology, infectious disease, and microbiology. So in our hospital, we have clinical hematology. We have a neutropenic, a transplant ID specialist, and he and his team and the microbiology head, they're all on one WhatsApp group. So whatever patients we have, we have about 25, 30 consults a day for infectious diseases. So every day, at the end of the day, we have a plan like this made for all our patients regarding what they're going to do. So ID sees them, puts out the plan in the group, and accordingly we act. When the blood culture flags positive, it's not sometimes just the hemat department that is informed. The ID is informed, and they directly make the changes in our patients. And that's what actually, this camaraderie between ID and hemat is actually what saves more lives than all the machines that I've shown you. So with that, I thank you.
Thank you, Dr. Samir. I would like to invite Dr. Kashi Vishwanathan to have a talk on ITP management for clinicians. Dr. Kashi Vishwanathan, clinical hematologist, Meenakshi Mission Hospital, Madurai. Thank you.
Good afternoon, everybody. At the outset, I would like to thank Dr. Ganesh for inviting me. And his motto is to popularize hematology. I think, not only in Andhra Pradesh, throughout India, I think. He's got so much energy, and I'm so happy to see him doing this every year and pulling up a lot of crowd and creating awareness on the topic of hematology. The topic given to me is ITP management for clinicians. Considering a time limit, is it only 12 minutes? I thought it was 18 minutes. Okay, I'll try. I will talk about the ITP and its management with case scenarios. Definition, primary ITP is an autoimmune disease, is isolated thrombocytopenia less than 1 lakh count, absence of other causes, and it's a diagnosis of exclusion. Secondary ITP is associated with any other autoimmune disease. The phases are newly diagnosed up to 3 months. 3 to 12 months is persistent ITP, chronic ITP is beyond 12 months. Severe ITP is anybody with symptomatic bleeding sufficient to mandate treatment. Initiation of therapy is called as severe ITP. It's a rare disease, predominantly occurs in two populations. One is the younger age group between 1 to 5 years, and in the age beyond 60 years. In the middle age group, adult females are much more common than males. And regarding the chronicity, children have lesser chronicity, about 20%, whereas adults have 60 to 70 become chronic ITPs. And CNS bleeds are rarer phenomena, but it's a major life-threatening event in these patients. It's about 0.45% in children and at about 1.4% in adults. Considering other major bleeding manifestations, about 20% in children, whereas it is 9.6% in adults. With the increasing duration of ITP, there is increased chance of bleeding. On long-term follow-up, about 15 years, about 10 to 15% have significant bleeding. What are the consequences? The major thing is mortality. And the rates from two different studies were a little varying. It was about 1.6 to 0.39 cases per patient year in one study, whereas it was much lower at 0.019 case per patient year. What are the main causes for the mortality? Intracranial hemorrhage, post and infection, which could be due to post-splenectomy infection, or you're giving immunosuppressive therapy for these because it's an immune disorder, you're giving immunosuppression. And the highest risk factors are elderly population, refractory patients with bleeding history, and patients with other associated bleeding disorder. And what is the pathophysiology? It is autoantibody mediated as well as T-cell mediated. And considering the thrombocytopenia, you can classify them as pseudo. Anybody with thrombocytopenia, you have to look at the peripheral smear, rule out pseudo thrombocytopenia. Platelet agglutination, it's a lab phenomena. It's a patients have a completely normal platelet. They don't need any treatment and they are completely fine to undergo any surgery, including cardiovascular surgery. And you should always look for peripheral schistocytes, which is a marker of microangiopathic hemolytic anemia. Today's morning talk was one of the talk which included microangiopathic hemolytic anemia. When you have this combination of hemolysis with thrombocytopenia, always think of this condition of microangiopathic hemolytic anemia. Decreased production is a primary hematological disorders. Increased consumption is what we commonly see, which everybody as a physician will see, and one of the diagnoses is ITP. Other diagnoses for increased consumption include sepsis, DIC, TTP, HUS, and heparin-induced thrombocytopenia. In pregnant patients, eclampsia, HELP syndrome, and acute fatty liver of pregnancy are important causes. When you have a thrombocytopenia, these are the investigation you should do. A CBC, peripheral smear, direct Coombs test, LDH, uric acid, which are markers of cell turnover, RFT, LFT, viral markers, because they can manifest. HIV and HCV patients can present primarily as thrombocytopenia as the first manifestation. Urine analysis, and you have to work for autoimmune disease with the lupus antibody, ANA, PT, APTT. If you are considering DIC in a sick ICU patient, if PT APTT is also prolonged, probably you're dealing with DIC, bone marrow is a diagnosis which will give an overall picture with a basic analysis. When there is a low platelet, rule out pseudothrombocytopenia, look for schistocytes. Fever, think of common tropical infections. And sick patients in the ICU, think of sepsis and DIC. Urinary tract infection, elderly population, thrombocytopenia can be a common manifestation. We should not treat them as ITP and the sepsis will worsen. Splenomegaly, think of hypersplenism or a hematological problem. Peripheral smear has to be looked up, and if there are blasts, we have to suspect leukemia, dysplasia, it could be a myelodysplastic syndrome. If everything else is normal, and if you do a marrow, and it is also normal, provided HIV, HCV is also negative, you diagnose ITP. So it's basically a diagnosis of exclusion. So the evolution of treatment, splenectomy has been described in 1916, and IVIG was used in 1981, and then there was a randomized trial of steroids versus IVIG treatment in the 84s, And then first report of rituximab was used between in the 1990s. And then we have recently the thrombopoietin analogs, romiplastim and L-Trombopac. And these two drugs are not available in India. They are approved in US. I'll go through a bewildering situation with ITP, 13-year female, present with headache to the casualty of 12 hours duration, associated with vomiting and drowsiness. She also gives a history of gum bleeding. The last 1 week, CT brain shows a SDH with a midline shift. CBC showed severe thrombocytopenia. Otherwise, it is normal. It is diagnosed as ITP. And there is this diagram depicts the severity of platelets and the risk of bleeding. The x-axis has the platelet count. When you look at that, when the platelet count is more than 50,000, you hardly have any severe bleeding. Only when the platelet count are less than 20,000, you are going to have a severity bleeding of grade 2, 3, or 4, which are grade 4 bleeding is spontaneous, uncontrolled bleeding. So don't panic if the platelet is more than 20,000. And this is a picture of a microbleed. This can happen if patients have a very low platelet, usually less than 15,000. The red bar shows the incidence of microbleeds based on the platelet count. If the platelet count, the far right, there is no bar. If the platelet is more than 15,000, you rarely see microbleeds. Only if the platelet counts are very low, you're going to see this type of microbleeds. So when in an emergency, that's patient is having extensive mucosal bleeding, it could be GI bleeding, genitourinary tract bleeding, or a head injury, or an IC bleed, we have to act immediately. Hematemesis, hemoptysis, we have to act immediately. What do? Transfuse platelets in such scenario to try to keep the platelet close to 30,000 or above. And platelet-derived interventions like steroids, immunoglobulin anti-D, or a combination of therapy and platelet infusion. Other supportive therapy includes cessation of antiplatelets, control of blood pressure, antifibrinolytic therapy, and recombinant factor 7A can be used in rare situations, which can be very helpful. If a patient has an active menstrual bleeding, OC pills will help you to stop the bleeding. So this is the immediate acting drugs, steroids, dexa, or prednisolone, IV immunoglobulin of anti-D. So when you look at the time duration of response, the IVG has the fastest response, which is about 1 to 3 days, and the usual duration of time to peak response for steroids is around 7 days. For prednisolone, dexa, it is little earlier, 4 days. So if you have a bleeding patient, instead of prednisolone, probably you can use dexamethasone. If the patient is not bleeding, probably use prednisolone because it's slightly lesser toxic than, lesser immunosuppressive than dexamethasone. So this is the ASH ITP management guidelines. When the adult patient with the newly diagnosed ITP, steroids versus observation. What should we do? If the platelet is less than 30,000 with symptoms, minimal symptoms, treat with start treatment. If the platelet count is more than 30,000 and asymptomatic, don't start steroid. Probably an option is to observe. Duration and type of steroids. Generally, recommendation is only one month therapy and taper it in the next 2 weeks and stop within 6 weeks. And either prednisolone or dexamethasone can be given as the initial therapy. And goal of therapy is complete response. We want a normal platelet count. That's what every patient will want. But I doubt this can be happen. But a safe platelet is more than 30,000. And coming to the second case, 72-year male with a newly diagnosed symptoms of epistaxis. He has hypercholesterolemia, hypertension, and diabetes. Platelet is 12,000. Diagnosis is ITP after your thorough evaluation. Frontline therapy is steroid, 1 mg per kg. He was started, but he developed very high sugars and hypertension. It was controlled with insulin and antihypertensives, and platelet count improved by day 7. So what should we give, dexa or prednisolone? Both are probably equivalently effective. Maybe in the short term, dexa is superior in inducing CR, but when we follow for longer duration, both are equivalently effective to a tune of about 30-40%. So there are a lot of steroid adverse effects, so be aware of it. That's the most important thing. We should not harm the patient. Diabetes, hypertension, infection, osteoporosis, avascular necrosis of femur, myopathy, mood swings, Cushingoid features, acne, and much more. Use of corticosteroid is a common problem. and studies have shown that they have been used for a prolonged duration in patients with ITP. And the next patient, a 28-year female who had responded well to prednisolone, after tapering steroids relapsed in 3 months. She does not want to take tablets. What do you want to give her? Probably rituximab is an option, and with rituximab weekly into 4 doses, she achieved remission. And we all know the mechanism of action is a CD20 antibody which kills the B cells, which are a part of the immune destruction of platelets. And there are studies which show excellent results. On long-term outcome, 29% of patients with ITP are in sustained chronic complete remission when rituximab is used. Coming back to the second case, 74-year male with epistaxis responded to steroid. Unfortunately, he relapsed after 2 months. Poor social support. He doesn't want to take rituximab weekly. Started on L-Trombopag, 25 mg. That's the initial dose is recommended for a lesser dose for the Asian population. And it has to be taken in empty stomach. 1 week later, it was slightly improved. Dose was increased to 50 mg, and after 2 weeks, the platelet was 1.2 lakhs. A 44-year male scenario, with chronic ITP, asymptomatic, more than 35,000 platelet, so he's not on treatment. He had a right femur fracture due to an RTA. He needs a surgery. What do we do? So in these such scenarios, probably L-Trombopag steroid you don't want to give in the perioperative period. He underwent, after L-Trombopag, the platelet improved, and he underwent successfully a surgery for the fracture. So be aware of thrombosis while on L-Trombopag or romiplastim. Don't think they are innocuous, and always exclude anti-phospholipid antibody. If you, by mistake, start this drug without checking for this antibody, and if they are APLA positive, in the next 1 week or 2 weeks, they may come with a serious intracranial thrombosis. And romiplastim, there's the mechanism of action. So this is the second line agents which are available. Rituximab, romiplastim, L-Trombopag. The last two are not available in India. I want to mainly point out is there is increased risk of thrombosis with romiplastim and L-Trombopag, and there is rebound thrombocytopenia when these two drugs are stopped. This is a 28-year female who responded well, and after tapering steroids, she relapsed in 3 months. She does not want to take steroids. So she was given rituximab. We have seen this patient. So, but later, 1 year later, again she came with low platelet, and she wants to become pregnant. Splenectomy was offered to her, and post 1 day after splenectomy, the platelets were completely normal, and then subsequently she had a normal uneventual pregnancy. Splenectomy, practical points: vaccinate for pneumococcus at least 2 weeks prior. H influenza and meningococcus vaccine is also optional. Even a 20,000 platelet is sufficient for undergoing a successful splenectomy. Post splenectomy, patients should be on pentid prophylaxis. Revaccinate them for pneumococcal vaccine every 5 years. Educate about post splenectomy sepsis for these patients, because there can be up to 1 to 2% mortality in the initial 2 years. That's a maximum period of infection which is going to happen in the post-splenectomized patients. Highly effective to achieve long-term CR, about more than 80%. So ITP in pregnancy, first trimester. So steroid, combination of steroids, mostly steroids in the emergency setting before surgery or delivery. You can give IVIG. In the last trimester, probably we can use thrombopoietin analogs. And these are the other drugs which are available: MMF, danazol, azathioprine. And so the rituximab, L-Trombopag, all are available, but they are costly. So how to choose, when to choose? For somebody who does not want injections or surgery, TPO analogs, L-Trombopag is an option. Who does not want short-term treatment, don't want oral therapy daily, who wants only a short-term therapy, only 4 weeks of therapy, rituximab is an option. Who wants long-term remission and more than 12 months from diagnosis, we can offer splenectomy. Are there cost-effective options? Rituximab is costly, L-Trombopag, romiplastim are costly. Yes, there are cost-effective options. This is a study from CMC, 300 patients, second-line treatment with either dapsone or azoran, 170 patients and 130 patients. CR and PR was seen in about 46% and 12.7% respectively. So total of 58%. So it's a reasonable option to try these agents, dapsone and azathioprine. Upcoming, these are the SYK inhibitors and FC receptor inhibitors. So these are upcoming. Probably this will help in the future. And to summarize, the frontline therapy is IVIG if there is severe intracranial bleeding or severe mucosal bleeding. IVIG in a selected patient, for example, an elderly patient with uncontrolled diabetes, maybe you don't want to start steroids, IVIG is an option. Steroids in most of the situations is the usual standard of care. And prednisolone or dexa, you can choose what you want. Rarely we use anti-D in our patients. Second line therapy, TPO receptor antibodies are generally preferred because of ease of taking, no need for injections, or rituximab. And rituximab can be used in TPO failures. And azathioprine, dapsone, MMF are the usual, the other simpler options, less costly options. And splenectomy is a very effective therapy. And if they are beyond 12 months, you better to offer splenectomy as a permanent cure for this disease. Thank you for the patient listening. Thank you.
Sorry, sir. I am a pathologist. Since 2 years, I have not seen any malaria cases at all in the peripheral smear. Second is, nowadays, the viral infection like dengue is very common in this part of Hyderabad and Secunderabad.
Yes, sir.
So, and then should we use corticosteroids, which is known to cause glaucoma and avascular necrosis of the femur?
For which patients, sir? For ITB patients, you're asking? For dengue? Generally, we don't use steroids on a routine basis for dengue, sir. If they have a HLH like a picture, with huge spleen, cytopenia persisting, fever persisting beyond the routine 1 week to 10 days duration, in such cases where you suspect a secondary HLH, in the selected cases, after ruling out infections, you can use steroids, not empirically for all patients with low platelets in dengue patients.
Thank you.
Thank you, sir, for nice presentation. Two questions are there, sir. One is, you spoke about prednisolone and dexamethasone, sir. What about methylprednisolone, sir?
Both are equal. Prednisolone and methylprednisolone are equivalent, sir.
So should we start methylprednisolone to start with, or dexamethasone, or prednisolone to start with?
If you have a symptomatic, significant bleeding patient, probably dexamethasone is more effective. When I put in the chart, the duration of response, time taken to respond, is slightly earlier in case of dexamethasone, which is about 3 to 4 days. Whereas for prednisolone, it is 7 days. So if the patient is not symptomatic very much, probably prednisolone is a safer option, reasonable option. If the patient has a persistent epistaxis, oral bleeding, probably dexamethasone would be a better choice.
One more thing, I have seen few hematologists using mefotenam meftolate first, sir, and few of them they use anti-fibrotic agent tranexamic acid. The patient is having epistaxis.
Yes, sir. Yes, sir.
So
that's a supplement. The tranexamic acid helps in stabilizing the clot which is formed. So it is always useful when you have a bleeding patient, any site, to add on, except genitourinary bleeding. When there is hematuria, we have to avoid tranexamic acid. Otherwise, we can use tranexamic acid for all these patients with the bleeding manifestation. It will help in stabilizing the little bit of clot which is being formed. So if you use it in a urinary tract bleeding, it can cause clotting and obstruction of the ureters. So it is in a hematuria patient, we should avoid it.
Thank you, sir.
Thank you, sir. Now we move on to our last session for today, a panel discussion on urgent hematology consults for physicians. I would like to invite Dr. S.P. Verma, clinical hematologist, King George Medical University, Lucknow, to moderate the session, And our panelist for the session will be Dr. Padmaja Lokireddy, Hemato-Oncologist, Apollo Hospital, Dr. Deepak Charles, Oncologist and Bone Marrow Specialist, Aster Hospital, Dr. Virendra Patil, Endocrinologist, Dr. Kundan Mishra, Clinical Hematologist, Army Hospital, Dr. Meet Kumar, Hematologist, Hisar, Haryana, Dr. Stita Pragna, Hematologist, Yashoda Hospital, Dr. Chaitanya, Hemato-Oncologist, Dr. Sri Saujanya, Emergency Physician, Yashoda Hitec City, Dr. Saumika, Medical Oncologist, Sindhu Hospital, Dr. Sitaram, Hematologist, St. John's Medical College and Hospital. Thank you.
Good afternoon, everyone. So at the outset, I would like to thank Dr. Ganesh for this opportunity and arranging such a high-tech program in this high-tech city. And I welcome all my panelists so that we can start the panel discussion. So it's a very important area for panel discussion, urgent hematology consults for physicians. So as we know that consultative hematology is a very important part of our practice in the field of hematology. So my panelists have already been introduced. So the first question, anyone, Dr. Deepak, maybe you can take it. So what are the common urgent hematology consultations? What are the common references or consultations we are asked to look for?
So from a ICU and an IP patient setup, it's mostly related to the cytopenias which we commonly see, either in terms of, most of the times it's thrombocytopenia, isolated thrombocytopenia, or many a time pancytopenia.
Yeah.
The second would be a bleeding patient, and the third would be regarding anticoagulation, many of the inpatient settings. These are the three common settings which we see.
So rightly, as you rightly mentioned, so these are the common things, no? Like the most common one will be, I think, the thrombocytopenia, as you mentioned, and then bi and pancytopenia. So any hematological abnormality in any other department which is not hematology, basically it makes a very important concerns for them how to manage, how to diagnose. So then it becomes a consultation from hematology to look into it and diagnose the condition. So I'll be going by some of the cases. So this case one, 50-year male, shopkeeper, no comorbidities and no addiction, presented in Department of Medicine emergency with off and on fever for 2 weeks, petechiae, purpura and epistaxis for 3 days, no lymphadenopathy, no organomegaly was there, and CBC showed pancytopenia. So this is the condition of pancytopenia, bleeding and fever. So what could be the possibilities? Anyone? Yeah.
So the first possibility we should always think about is tropical infections.
Yeah.
The next would be any autoimmune causes. Next would be any hematological, primary hematological disorders such as leukemia, or we'll be thinking about MDS and everything.
Yeah. So whenever we get these patients with pancytopenia, fever and bleeding manifestation, we think about, maybe it is a plastic anemia or MDS, maybe it is some acute leukemia, or maybe some acute viral induced myelosuppression, because sometimes we get these cases also, or severe infection, sepsis, autoimmune conditions. So as you rightly mentioned, so how will you work up this case, sir?
So the basic thing, so we just classify them into hematological investigations, biochemical investigations, microbiological investigations, so that you don't miss anything. Start with a complete hemogram, peripheral smear, a direct Coombs test, and then biochemical tests. You look for liver function test, renal function test, and electrolytes. And then you look for the microbiological infections.
So the approach should be holistic, so we should start. But the first and foremost important thing which we have to remember is that in such cases, CBC and peripheral smear examination is one of the very important points. As you see, sometimes when the TLC is very low, there is no mention of differentials. And sometimes the residents, they overlook because there are very few cells, so they do not see those cells and do not comment on that. That can lead to delay in diagnosis in such cases. So what I'm missing here is, because I have just mentioned about the CBC, not about the smear. So I'll give you the picture of smear. So this is the peripheral smear examination, and these type of cells are there in this patient. So what will be the next step in this patient?
So the peripheral smear is showing the classic promyelocyte, abnormal promyelocyte. So this is a case of APML. So immediately once you suspect any APML, because it is a high risk condition which requires emergency management, we need to we need to start ATRA immediately, and we need to arrange for all the blood products which has to be given as required based on the fibrinogen platelet count. We need to maintain levels of platelet more than 30 to 50,000, and fibrinogen cutoffs have to be maintained more than 100 to 150, and prompt initiation of ATRA.
So it's very important to recognize this entity. You know, in APML, very frequently we see that patients present with pancytopenia and bleeding manifestation. It's not like always you will get a high count or normal count. So sometimes there is severe pancytopenia to present with, and these can be mistaken for aplastic anemia or some other condition if the peripheral smear is not taken care of. And then when we get this condition, then we have to be very prompt. This has to be very strong, talk between the pathologist and hematologist, so that they can report this very early, because these are medical emergencies. So in this condition where we have diagnosed this patient, so we have to send the samples for FISH or PCR for confirmation. Simultaneously, we have to start ATRA immediately. What is your opinion about these procedures, ma'am? These procedures: bone marrow, central line placement, CSF evaluation, leukapheresis, in these patients where we are suspecting APML.
Being in the emergency department as an emergency physician, central line is one of the common things, but it makes us very, anxious to do a central line if the thrombocytopenia is there because of the bleeding risk. Yeah. And definitely we also look for, if there is any pancytopenia, we definitely call for a hematology consultations and take up for bone marrow and CSF evaluations.
So, Dr. Deepak, like all these procedures, your comments?
In a patient with a suspected DIC and APML, I wouldn't attempt a CSF evaluation or central line unless I'm stabilizing the patient. Leukapheresis is only in like the variant APMLs, but rarely we have to attempt that, because we always do cytoreduction with medications, hydroxyurea or low-dose cytarabine upfront to reduce the WBCs.
So definitely. So bone marrow is indicated because that is a preferred sample for sending the molecular studies, sending FISH, and for flow cytometry if you are not having adequate cells in the peripheral blood. But central line CSF evaluation and leukapheresis should be avoided as much as possible. CSF evaluation in those patients with high risk APML presenting with more than 10,000 total counts can be done at the end of induction, and just to give the prophylactic triple intrathecal therapy if you consider your patient is at high risk of CNS relapse. So with this, these are the guidelines, ELN guidelines, which mentions that whenever you suspect APML, start ATRA immediately, because that is the only thing which can save your patient. Send all the relevant investigations and arrange for the blood components, because you have to be very generous in supporting these patients with cryoprecipitate plasma and platelets. The platelet threshold in these situations is higher. It is 30,000 and not 10,000, which we routinely use for other patients. So now coming to case 2, this is 18-year girl, presents to medicine emergency with high-grade fever for 1 week, altered behavior for 2 days, and 1 episode of GTCS, which she had recently, and then she gets admitted. There is past history, no similar history in the past, no history of seizures in the past. She is conscious but had some mild disorientation. Pallor is there, no lymphadenopathy, no organomegaly. Cardiac, respiratory, and other system is normal. Okay. So this patient with high-grade fever, altered behavior, 1 episode of GTCS, and anemia. So what are the possible differential diagnoses in this patient, as this patient is coming to medicine emergency?
So again, here again, when you think of a young patient presenting with fever, altered sensorium, your first initial suspicion would be a cerebral malaria. From a hematological point of view, we always tend towards the IC bleeds and everything, but they generally don't present with fever. But as a hematologist, I would always have a high clinical suspicion for the TMAs, the TTPs, whether be it inherited, acquired, or atypical HUS as well.
So in routine practice, you rightly mentioned, but in a general medicine emergency department, when these patients come with, such type of seizures, fever and all, we think of meningitis, encephalitis, brain abscess, cerebral malaria, complicated enteric or dengue, vasculitis, and there can be some other rare conditions also. So how will you approach this patient, Dr. Deepak?
No, so again, it's basically the basic investigation which should be done upfront with a blood count and smear. You can always look for a malarial parasite, and the basic chemistries has to be done. Smear interpretation is especially very important in this situation because it gives you many clues to what could be the possibilities, like whether it's a microangiopathy happening. Yeah.
So CSF evaluation, scanning of the brain, and then autoimmune workup, HPLC. Sometimes sickle cell can be a cause in younger patients like this.
In young patients, especially, we have seen SLE patients present.
SLE. So that's what. So autoimmune and vasculitis in younger patient with such type of presentation, of course. So in this patient, this is the CBC. Hemoglobin is 7, TLC is 4,500, platelet 25,000, MCV is 85, and no evidence of malaria parasite in peripheral smear. Retic is 10%. Urea and creatinine is deranged 1.5. Bilirubin is 3, direct is 0.4 milligram per deciliter, so there is indirect hyperbilirubinemia. PT-APTT is normal. And CSF evaluation is within normal limits. Malaria, dengue and typhoid is negative. But MRI brain shows this type of lesions. So these are infarcts in different areas of the brain. You can see multiple infarcts in this MRI brain. And review of peripheral smear, when it was asked to look at the peripheral smear, the pathologist noted this. This we have seen in the previous presentation also. So what is your probable diagnosis? Now with these findings, what is the probable diagnosis, and what is importance of hematology consult at this time point? How this entity becomes very important and very emergent situation? Sir, you can take it.
Okay, the smear shows schistocytes. The moment we see schistocytes, we're quite worried whether we're dealing with the TMA or TTP kind picture, especially in the context of seizure the child presented with.
Focal neurological deficit.
So, yeah, that would be our first this thing. So it's a medical emergency. So I would actually repeat the blood parameters again, look at the coagulation parameters, do the same basic workup, hematological, biochemical, microbiological, and autoimmune. So if we strongly suspect TMA, which in this case we are, we should try to take the sample early and freeze it for ADAM-TS13 levels because it may not be readily available. And then we should have a very low threshold. I mean, if it comes to a physician, obviously you need to try and speak to a hematologist as soon as possible. If in doubt, I would probably give FFP upfront and some steroids as well. And then whilst we're waiting to stabilize the patient, and then try and get into plasma exchange as soon as possible, preferably within 24 hours.
Thank you. So understanding this situation is very important because this is medical emergency. We are dealing with a patient who has got TMA. And if you are not treating this patient in time, the mortality is somewhere around 80 to 90%. But if you treat this patient, take up this entity early, recognize this entity early, then the survival is almost 90%. So it is just a reversed situation. Okay, and then it is a multidisciplinary approach because you have to look at plasma exchange, so you have to talk with the transfusion medicine department, you have to talk with the critical care or the facility where this plasma exchange facility is available, if not in your department. So what are the clinical features and how to suspect this, like TMA or this situation which we are discussing? What are the usual clinical features in this patient? Just for the physicians and for other entity or other department persons, how to suspect this? Anyone? Yeah.
So most commonly they present with fevers and neurological symptoms are there. So the classic pentad which we usually described in TMA, like the fever, neurologic involvement, renal involvement, and anemia, thrombocytopenia are all not seen usually in all the patients, but definitely anemia, thrombocytopenia is seen because it is a microangiopathic hemolytic picture. And neurologic symptoms are seen in around 40% of the patients. So these are the most common presentations which we see.
So very rightly mentioned, ma'am. So we can see that, fever, as such, we consider it as a very important entity, but fever is not there in all patients. Only 10-15% patients will have fever. The most common finding will be anemia and thrombocytopenia, and the cause of anemia will be the fragmentation anemia. So you will get cystocytes in the peripheral smear. Along with that, neurological presentation is much more common. So so it can be a severe coma, seizure, focal neurological deficit, or it can be a simple headache, which is persistent headache. So persistent headache, anemia, severe thrombocytopenia. Probably you are dealing with the TMA condition, although the patient is stable and not had developed any focal neurological deficits. And that's why these neurological manifestations are very important to understand that it can be a TIA, it can be simple confusion or headache, it can be stroke, seizures, coma. So any sort of neurological manifestation can be there in these patients. So in these patients, what are the battery of investigation while workup this patient of TTP is advised? Anyone? Dr. Deepak?
So the most important thing is whether this being a young kid, whether it's an acquired or a congenital TTP, although it happens in the background of fever. So first thing will be an acquired TTP in the background of an autoimmune disease. So we'll be working up for the autoimmune disease in that panel. And also to confirm the TTP, we need the Adams 13 assay. It's very important to get the blood, as Dr. has mentioned, to before any transfusions has happened. Before the plasma has been infused, you have to get the sample for the Adams 13. And based on which we'll further decide on the management profile.
So very rightly mentioned, because this Adams 13 activity and inhibitor testing is quite costly. So it involves around, maybe if both tests combined, maybe somewhere around 25,000-30,000 rupees. And all the patients are not able to do that, in timely fashion. So probably storing the sample can be one thing before you go for plasma exchange or plasma infusion. But along with that, we have to rule out DIC in such situations. So coagulation workup is very, very important. And then you have to demonstrate that there is ongoing hemolysis, so heptoglobin levels, indirect hyperbilirubinemia, high LDH, all these are important features of this. So if Adams 13 testing is not available, as we are talking about, is there any scoring or model to predict possibility of TTP in such clinical situation?
Yes, sir. There are two scoring systems that are there to predict the risk of ADAMTS13 deficiency, the probability of ADAMTS13 deficiency. One is the French score and other is the plasmic score. The plasmic score, if you have a high plasmic score, there is a high probability of having an ADAMTS13 deficiency. It does not tell us whether the patient is having a TTP or not, just gives the probability of ADAMTS13 deficiency.
Thank you. So this is poor man's Adams 13. So this can be used bedside with all the available parameters to just predict how much possibility is there that this patient will be having Adams 13 less than 10%, which is one of the diagnostic criteria. And if you have a score which is 6 or 6 to 7 based on these parameters, which are the routine parameters, we can see the chances of Adams 13 being less than 10% is somewhere around 60 to 70%. So the chances of TTP is very, very high, and that's why these scores are going to help. How do you interpret Adams 13 activity report? So actually, because we get levels of Adams 13, so how do you interpret as such? Like if it is 10%, less than 10%, 10 to 20%, what are the implications for that?
The routine cutoff which we take to diagnose it as ADAMTS13 deficiency causing TTP is 10%. So if it is less than 10%, we attribute it to severe deficiency which requires immediate management. And the other more than 10%, it is non-specific. I mean, it can happen in other situations as well.
Yeah, so some of the malignancies or some of the secondary TTP causes can also lead to Adams 13 deficiency. But if it is less than 10% in the appropriate clinical setting, so that is very, very important, that apt clinical setting, Adams 13 level less than 10% are almost diagnostic of this entity. And so these are the differential diagnoses. We all know that TTP and HUS are very closely mimickers, then drug-induced TMAs, complement-mediated TMAs, and then there are so many pregnancy-associated conditions which can, give rise to the similar picture and their role of differentiation. So how to manage this case? Like sir has already touched upon that plasma exchange is the method to go. So we have to go for urgent plasma exchange, and that is where the consultation comes. So because there is always a confusion in whether to go for plasma exchange or not, and that is the point where hematology role comes up. So in a very apt clinical setting, having plasmic score suggestive of TTP, probably it is better to go ahead with the plasma exchange rather than waiting for Adams 13 reports or inhibitor report. and that is the way to go ahead. So now coming to pregnancy, these are the most common consultations in hematology practice. Thrombocytopenia in pregnancy. What are the causes of thrombocytopenia in pregnancy? Such anyone? Sir,
the most common cause that we deal is gestational thrombocytopenia, but again, you always see the immune thrombocytopenia which is coming up, and the primary pregnancy conditions like pregnancy-induced hypertension, preeclampsia, HELP, all of these can cause thrombocytopenia. Not only this, we also have these autoimmune conditions which tend to flare up during pregnancy, like SLE which can flare up, which can cause thrombocytopenia. So all these can happen. Not only that, we have these microangiopathic hemolytic anemia that is going on. So again, TTP will again come into play here.
Yeah, so as you just mentioned, it can be pregnancy specific or non-specific. So we are talking about gestational thrombocytopenia, which is the most common, which is pregnancy specific thrombocytopenia. Preeclampsia, HELP, and are also pregnancy specific, but there can be ITP and other causes of thrombocytopenia which are non-pregnancy specific, and the rare the cause. All the rare causes are almost serious causes of thrombocytopenia in pregnancy, so that's why we have to be careful. Although they are rare, but they are not, non-serious. They are very serious. So how to differentiate between gestational thrombocytopenia and ITP? Because this is one of the very important concern, and you will get phones, every time. Sir, platelet count 70,000 है, 80,000 है, क्या करें, क्या ना करें? So how to differentiate between this gestational thrombocytopenia and ITP? Deepak.
So most of the time, gestational thrombocytopenia is very mild. Usually, we don't see platelets going beyond, say, 75 or below, and it happens in the third trimester.
Yeah.
And if you have a past history, you can check the previous records of the patient when the onset of thrombocytopenia. That also gives an important clue as to differentials.
Yeah. So there are certain other features also, as you rightly mentioned, that if platelet count is beyond 70,000, mostly in gestational thrombocytopenia, any time during pregnancy, it should not come below 70,000. Although there can be rare instances like that, but if it is less than 70,000, then probably either you are dealing with ITP or some other pregnancy associated complication, because these things they get accumulated in the late second or third trimester, where the differential diagnosis becomes very wider. So even we are considering GT, but that cannot be GT, that can be onset of some other more severe type of disease like preeclampsia or HELP. So that's why it's very, very important to differentiate. So how to approach thrombocytopenia in pregnancy? So we have so many causes, varied causes. So how do we get to the conclusion that probably this entity is responsible for the thrombocytopenia?
Again, it depends. You have to see in which trimester of pregnancy. So it's whether first trimester, second trimester, or third trimester of pregnancy. And also you have to look for pregnancy-associated complications like hypertension, preeclampsia, and do relevant tests. So again, basics, your CBC, your liver function test, electrolytes, they all give you a clue as to which way we are heading. So you've actually put a big table there.
Yeah, so it's the table is big, and the confusion is also very big. So sometimes there is a good mixture of the findings, and it becomes very difficult to differentiate which particular entity is responsible for this thrombocytopenia, as you mentioned. But yes, we have to put some emphasis on some of the basics, like if the patient has is a diagnosed case of preeclampsia or pregnancy-induced hypertension, HELP, then probably that. So hypertension, presence of hypertension, proteinuria will put you towards that etiology, preeclampsia or HELP as a thrombocytopenia. If patient has got significant liver dysfunction, enzymes are going very haywire, then probably we are dealing with acute fatty liver of pregnancy. Patient will have recurrent hypoglycemia. Patient will have significant renal and hepatic dysfunction. So all those things we have to consider while making the diagnosis or coming to a probable diagnosis in this patient, because ultimately we have to decide what treatment we are going to offer, whether we are going to ask the patient for termination of pregnancy faster, or we are going to ask for a TP from plasma exchange. So that becomes very, very important. Now coming to case 3, this is a 30-year-old lady, day 4 postnatal PNC. So delivery by cesarean section outside. She was referred to gynae and obstetric department. In shock, anuria, and bleeding from surgical site as well as venipuncture site. So what is the possibility and prognosis in this patient? Because again, this is one very urgent consultation from hematology. Ma'am.
So there could be acute renal failure in this patient secondary to disseminated intravascular coagulation is one of the possibilities. And we also have to look at the other causes of any sepsis or septic shock. Postpartum sepsis with septic shock has to be considered. And what are the blood, we have to work up these patients in terms of complete blood counts, metabolic panel, renal function and liver function test to come to a diagnosis what we are dealing with.
Yeah, so along with that coagulation profile, because the patient is bleeding, so she had got anemia, severe thrombocytopenia, adherence, PT and hepatitis, so we are dealing with DIC. And why it is important to diagnose this entity in timely fashion is that the second name of DIC is death is coming, and the mortality is almost 60 to 70% if not taken care of in time. So what are the causes of DIC, ma'am, in pregnancy? As such, in pregnancy, what can be the causes of DIC? Like one is infection. Post-op patient has got infection that is not related to pregnancy. But what are the other causes of DIC in pregnancy which we have to take?
Abruption is a main cause, most common cause which can cause DIC in pregnancy, and as you told, sir, severe sepsis can cause, placenta previa can cause. So these are the main causes which can cause septic abortions and all.
Yeah, so along with infections, which are the major cause, especially when the patient is operated in not a very hygienic setting, the other causes which are pregnancy related can be abruptio placentae, as you rightly mentioned, and then placenta previa, retained fetus, dead fetus, amniotic fluid embolism. So the importance of knowing this is that we have to correct the underlying cause first. If you want to save your patient, you have to correct the underlying cause first. So any scoring system in DIC, like again in DIC also there is always confusion whether it is DIC or non-DIC. So any scoring system in DIC?
So the ISTH committee has given us a scoring system which includes platelets, fibrinogen, D-dimer, and PT prolongation. So all of this which help us if you have a high score, high probability of DIC is there.
So very right. So you rightly mentioned, so there are scoring system. If there is any confusion, we have all the parameters bedside. We can put these parameters into the, even the calculator available in the phone, and we can, just come to a conclusion that probably it is a DIC or over DIC or, covert DIC. So the management is treatment of underlying cause, as we just discussed, and then supportive care is very important here. Again, plasma, FFP, cryo, platelets, a higher platelet threshold is required in these cases. So this is the last case, only 2 slides are there. So 35-year male presents in surgical emergency with severe persistent right hypochondriac pain and fever for 2 days. History of similar pain has been there on past 2 occasions. Emergency ultrasound abdomen shows acute cholecystitis, and he is on dabigatran 150 milligram BD for recurrent lower limb thrombosis for not identified cause as such. And surgeon wants to do the emergency lab cholecystectomy in these patients. Emergency consult is, sent. So how to manage this patient?
So in these situations, first of all, if the surgery is an emergency, that has to be prioritized. We have to think of stopping the anticoagulation and think of reversal agents if the risk of bleeding is considered high. Dabigatran, this patient was on dabigatran, which means it could be reversed. We have specific agents which is not easily available. What we can offer is plasma infusions, and dabigatran is good things. It can be dialyzed if required.
So very rightly said. So these reversal agents.
Can I just start up
yeah,
to
please.
So most important thing to find out is when is the last time the patient has taken the drug.
Yeah.
So it's beyond 10, 12 hours. Then you kind of know that the majority of the drug is out of the system. Specific to dabigatran, you look at the thrombin time, which is quite sensitive. If thrombin time is normal, then you're fairly certain that there's no dabigatran in the system.
Yeah.
So I just add.
Very rightly said. So as we know that the onset and offset of these DOACs, the newer and oral anticoagulants, is very small, maybe 8 to 10 hours. So that's why if the last dose was taken maybe 12, 24 hours back, then probably patient has washed out all the drug. But if it is recently patient has taken the recent drug, then we have to cover with this. So in that context, we're talking about that the antibody and andexanate for other agents is not routinely available, and that's why the common practice is to use either APCC or PCC or plasma, whichever is available in emergency situations. The dose is 25 to 50 units per kg body weight. And if you see the real world scenario also, therapies for DOAC's reversal prior to emergency surgery. In the real world, in a Western world also, most of the commonly used products are FFP, 3-factor PCC or 4-factor PCC rather than DOACs. DOACs are used only in 1/3 of the patients. As such, DOAC antidotes are used in 1/3 of the patients. And as you rightly mentioned that thrombin time is somewhat sensitive to dabigatran. So the real test which is really sensitive to this molecule is dilute thrombin time or eccarin clotting time ECT, which are actually not routinely available in most of the coagulation labs. So it's difficult to as such predict on that. But rightly said, like offset and onset of action can be taken into account, and if that is there, then probably drug is washed out. If it has been taken very recently, then we have to use FFP or 4-part PCC or 3-part PCC. So the take-home message from this presentation and discussion is that effective hematology consultation includes determination of the question being asked. So you will be asked for consultation, and there will be one question what to do, whether to go for exchange, not to go for exchange. Establish the urgency of consultation and respond in timely fashion. The time is life. We have seen in these cases, so that's why it's very important to be very serious on that matter. Communicate briefly and address specific questions which are asked, and make specific recommendations regarding treatment, so that the person who has asked the consultation is not swayed away and he is onto all those 3 or 5 or 6 investigations which we have advised. Anticipate alternative diagnosis, because as we have discussed DDs, so always keep in mind the DDs. It can be malaria, it can be TMA. So both things we have to consider if in that appropriate clinical situation. Provide relevant evidence-based literature and guideline also to the person who is primarily taking care of the patients. Direct verbal communication with the physician who is taking care of the patient primarily is very important, because that makes the things much clearer rather than going through resident and then CNRN and then the consultant. So that will also save time, and the things will be happening fast. And provide adequate follow-up and note the progress of the patient, how the patient is doing, because all hematology patients cannot be managed under hematology setting, because the variety of etiologies, variety of presentations. So all the other departments take care of these patients, and we are the one who can provide consultation in timely manner, so that they are also confident in treating the patient. So I thank all my panelists for active participation, and again thank Dr. Ganesh for this opportunity. Thank you. Yes, please. One question, panelists. Sir को mic दीजिए. Sir को mic दीजिए.
Thank you, sir. I would like to know, in placenta previa, sir, how patient presents with DIC. Because in placenta previa, it is the location of the placenta, whether in the upper segment or lower segment, according to grade 1, 2, 3, 4. So here is a placenta previa's definition is painless, causeless, bleeding PV. So how does the DIC occurs in placenta? Because it has been mentioned.
Sir, it has been mentioned that is disruption, placental disruption, retroplacental hematoma. These are the situations when patient develop DIC. It's not only placenta previa. The location will not cause DIC, but because of the location, the complications which are happening, the disruption which is happening, that will cause DIC.
How much is the incidence, sir, the prevalence of the placenta previa causing DIC as compared to the
So when we have this DIC, if you do ultrasound, you will see that there is some retroplacental hematoma accumulation, or there is placental abruption. So those are the reasons. They are rare. They are not very common, but they are rare causes of DIC, but they are there. We cannot exactly comment on what percentage of patients will be having this placental abruption. But if it is there, even a slight abruption is there, and your patient is getting sick, and the hematological findings are supporting that probably your patient has got either covert or overt DIC. The thing is that you have to take out the placenta, you have to terminate delivery. That is what you have to take the steps, early steps.
Thank
you. Question hai?
Question. Thank you so much for the wonderful presentation. And I have one question, just curious to learn how in real time, how can I differentiate HUS from the TTP? Because given the, the probability of pentad is less than 10%, and we are going to see hemolysis with ongoing reti count is going up and high LDH. And how confidently I can start plasma exchange in TTP, and how I'm going to rule out HUS, because when I see patients where I really don't get enough history that if the patient has any ongoing diarrhea, and yeah, how I'm going to analyze the situation in real time.
Anyone from the, you want to take?
When you have TTP, your primary presentation is more neurological oriented. When you have HUS, your primary presentation is more kidney oriented. Okay, that is one way you can differentiate. There's no definitive evidence to tell that you can differentiate between TTP or HUS directly. When you have a clinical suspicion of a microangiopathic hemolytic anemia, you always start plasma exchange, be it TTP, be it HUS. You test for the ADAM-TS13. Once the ADAM-TS13 comes, you will know whether you are dealing with TTP, TTP kind of a picture or a HUS kind of a picture. Once you have ADAM-TS13 deficiency, then you will be testing reflexively. The lab only will test for the antibody also. So that antibody positivity will tell you whether it is an acquired or an immune TTP. So until you get the ADAM-TS13 deficiency, you will not know. Until that time, you have to go on with plasma exchange. No, there's no absolute contraindication. You have a microangiopathic hemolytic anemia, you can start TTP, plasma exchange.
So basically, if in doubt, plasma exchange is not going to harm the patient.
Thank you. Thank you.
I request all the faculties and the delegates to please stay with us for another 2 to 3 minutes. We are going to have a group photo. I can see, thank you so much to all the eminent our physicians from our region. I can see more than 100 distinguished clinicians still in the auditorium. That speaks about, that is the testament to the curiosity, enthusiasm you have about hematology and the kind of inclination to get involved into hematological spectrum and hematological diseases management. I'm really grateful to one and all for such a exhilarating and very exciting journey of 36 hours going through the practical essential hematology and then also incorporating the future of hematology, hemato-oncology, bone marrow transplant. So we now conclude this 36 hours of 1.5 days Deccan Hematolink 2.0, and I take this opportunity to share my humble, sincere gratitude to each one of you, part of Deccan Hematolink 2.0, and your enthusiasm, your curiosity, and your relentless support is the driving force for organizing such hematology-themed conferences in this region. And we look forward to another version of Deccan Hematolink 3.0 next year with more and more futuristic hematology topics and more involvement by all our our own Telugu community representing hematology from the region. So we conclude Deccan Hematolink 2.0 with a great positive note with 100% involvement by each of you. Thank you so much again. And I request, before we conclude this session and break out for lunch, all the faculties please to collect your mementos from the faculty, the memento desk next to our photo booth. And everybody, please have your lunch before leaving this Deccan Hematolink